Human Services. This is a different than usual meeting for us because we're also partnered with the folks from Appropriations and Financial Affairs. We'll be hearing from Director Probert about the main care rate study, give us an update on that and find out where we're going. That's the morning activity with some book reports to follow. And then in the afternoon, we'll have some public hearing on specific bills. If you'd like to watch as well as listen, you can go to legislature.maine.gov and look up Health and Human Services, HHS. We have our very own YouTube channel, and you can go there now, or you can see it recorded later on. All those are saved. We won't be having anybody testifying in the traditional manner this time. I've remembered to turn off my cell phone, and the chat is to be used for moving the committee ahead, not for anything else. So thank you for that. Why don't we go around the room and introduce ourselves? I'll defer to our guests to begin with and ask if Senator Breen wants to call out folks in order.
Thank you, Senator Claxton. Why don't we start with Representative Cloutier?
Thank you, Madam Chair. Good morning, everyone. I am Kristen Cloutier. I represent House District 60, which is part of Lewiston.
Representative Corey.
Good morning. I'm Patrick Corey. I represent House District 25, which is part of Windham.
Representative Hymanson.
Good morning, everyone. It's nice to see HHS sitting here in my reveries. I'm Patty Hymanson. I represent House District 4, which is parts of York, Wells, Sanford, and all of Ogunquit.
Representative Arata.
Good morning. My name is Amy Arata, and I represent House District 65, which includes New Gloucester and part of Poland.
Representative Fay.
Good morning, everyone. Thank you, Madam Chair. I'm Representative Jessica Fay. I represent House District 66, which is parts of the towns of Casco, the other part of Poland, and Raymond.
Representative Millett.
Thank you, Madam Chair. Good morning, everyone. Someone Millett, House District 71, towns of Norway, Sweden, Waterford, and West Paris.
Senator Davis.
Thank you, Madam Chair. Good morning, everybody. My name is Paul Davis, and I represent Senate District 4, which is all of Piscataquis County and parts of Somerset and Penobscot.
Senator Bailey.
Thank you, Madam Chair. Good morning, everyone. I am Donna Bailey. I represent Senate District 31, which includes the communities of Saco, Old Orchard Beach, Hollis, Leamington, and part of Buxton.
My co-chair, Representative Peirce.
Good morning, Teresa Peirce. I represent House District 44, which is the majority of Falmouth.
And I'm Kathy Breen. I represent 6.5 communities in Cumberland County in the state Senate. I serve as Senate Chair of Appropriations. And we are really appreciative of HHS hosting us today. Obviously, the rate study has big financial implications. So it's really a great opportunity for us to begin to learn what's underneath the rate study and how it might affect the state budget going forward. So thank you for having us.
Glad you could join us. And at HHS, we'll start with Representative Zager.
Thank you, Mr. Chair. Good morning, everyone. My name is Sam Zager. I represent District 41 in Portland.
Representative Lemlin.
Good morning, everyone. My name is Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
I think I saw Representative Stover earlier. Yes, there she is.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, West Port Island, and part of South Bristol.
I haven't seen Senator Baldacci yet. There she is. Okay, welcome, Senator.
Good morning. I'm Joe Baldacci. I represent the city of Bangor and the town of Herman. It's great to be with our friends on AFA who did such a great job in the last couple of weeks. So thank you. Great to be here.
Representative Perry.
Good morning. I'm Representative Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Cadescade, and Levant.
Representative Connor is probably over at HCIFS. Representative Craven.
Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Working on two screens, so I haven't seen Representative Madigan yet. Okay, Representative Javner.
Good morning. I'm Representative Kathy Abner, and I represent House District 141, which is located in Penobscot and Washington County.
Senator Moore.
Good morning. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Good morning, and thank you to everyone for joining us here this morning. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is parts of Kittery and South Berwick, and all of Elliott. I would also like to wish a happy birthday to my Senate co-chair, Senator Claxton.
Thank you very much. It's an accomplishment. I'll leave it at that. My name is Ned Claxton, and I'm proud to serve the folks of Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. Our committee is incredibly well served by our staff. I haven't seen Anna.
I'm here.
There she is. Thank you. Welcome.
Hi, I'm Anna Broom, and I'm one of the nonpartisan staff at the Office of Policy and Legal Analysis.
And Erin Dooling.
Good morning. My name is Erin Dooling. I'm also one of the nonpartisan analysts for the Office of Policy and Legal Analysis.
And our very now experienced clerk is Carrie Withy.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
Before we proceed, I see we've been joined by a couple of folks who didn't have a chance to introduce themselves before. Do you want to fill that in? Did we
It looks
hear?
like Representative Martin and Representative Cardone have joined us. Representative Martin, do you want to start?
Sure. John Martin, House District 151, Northwestern Aroostook County.
Representative Cardone?
Cardone, House District 127, part of Bangor.
And I also see Maureen Dawson's here.
Thank you. Yes, Maureen is the analyst for appropriations from the Office of Finance and Policy, OFPR. Thank you. And happy birthday, Senator Claxton.
Thank you, Senator. We also are joined by our special guest today, Director Probert. We're anxious to hear what you've got to say. Would you prefer to have questions as you go along, or would you prefer to try and get through certain segments and then open it up, or do the whole presentation? Because I know you're a big PowerPoint person. He says appreciatively.
Thank you. How about I will go through sections and pause as appropriate for questions as I go along.
And since I'm in charge of making sure I don't miss people, could you use the raise hand symbol at the bottom of your screen? And I will try and recognize you as quickly as I can. Molly Bogart is also here from DHHS.
Good morning. I'm Molly Bogart, Director of Government Relations for DHHS.
Welcome. And Mariana Edmonds is in the attendee room. Does she want to join us, or do you have a? Okay. Well, we'll wait for her to ask. All right. So the floor is yours, Director Probert. Thank you for being here.
Thank you very much for having me, Senators Breen and Claxton, Representatives Person Meyer, and members of the committee. I'm very pleased to be joining you this morning to talk about MaineCare's comprehensive rate system evaluation. And I will join others in wishing Senator Claxton a happy birthday. I haven't been in a meeting where there's been a Zoom sing-along yet. We could make that a first, but I will spare everybody from that dubious pleasure of at least listening to my voice. I will share my screen so we can get started here. Okay, does that look like it's supposed to in terms of the slide? Yes. Okay. It always feels like it's a crapshoot whether or not it's going to show up the way you want it to. You'd think that we'd all figure this out after a while. In any case, good morning. Once again, my name is Michelle Probert. I am the director for the Office of MaineCare Services. A little bit of background as it may be relevant. I've been in my current position for 2 years. I was with the Office of MaineCare Services previously from the time frame of about 2011 to 2014. During that time, I was the director of value-based purchasing and helped to set up the state's Medicaid Accountable Care Organization, as well as our Health Homes Initiative. And so I have quite an interest in how we pay for care and how that can influence the outcomes of care. I also will share that in the interim between the last time I was at MaineCare and this current time, I was on the private purchaser side of things. I was in charge of healthcare strategy for Bath Iron Works and was also very involved with the Healthcare Purchaser Alliance of Maine. And so I bring to this topic those perspectives as well, and not just the perspective of a public payer. So I will start as a reminder to let everyone know that MaineCare is Maine's Medicaid program. Medicaid provides health insurance coverage. In Maine, we cover almost 350,000 at this point lower income Mainers, and that coverage helps ensure that individuals can receive critical services like vaccines, doctor appointments, and substance use disorder treatment. Like any health plan, rates are really important for MaineCare. They are really the way that we ensure access to services for members. Unlike other payers, however, we do have certain requirements that we have to meet in terms of the rates that we pay for services. Section 1902A 30A of the Social Security Act specifies that states' Medicaid payment rates need to be consistent with efficiency, economy, quality of care, and also that those rates need to be sufficient to provide access to the general population. And I will refer back to a number of these words multiple times because I think that they are all very important when we talk about the rates that we pay for services. Oops. I also wanted to note that another difference between MaineCare and other health plans is that we need to get permission whenever we want to make changes to what we pay. And that is in part related to the requirements for reimbursement that we face from the Centers for Medicare and Medicaid Services, or CMS. That is also because state Medicaid programs have to get federal authority for pretty much everything that they do. And so if we change the way that we are going to pay for services, we either need to submit what's called a state plan amendment, which we like to give the nice acronym of a SPA, so it sounds more fun than it is. So we either need to submit a state plan amendment or in certain cases, a waiver amendment to CMS for their approval. That approval at its very fastest, once submitted, will take 3 months. It usually takes significantly more than that as the clock is stopped for back and forth questions and answers with CMS. The state plan amendment or the waiver has to detail what Medicaid members are covered, what services are provided, the methodology for reimbursement, and when there are waiver services, for example, we have home and community-based waiver services, there are also additional requirements that services need to be cost neutral, which obviously also brings us back to the question of what the rates are. And those services need to be evaluated on a regular basis. I will share with the committees that there has been quite a recognizable trend in the past number of years where CMS has increased its scrutiny of rates and reimbursement methodologies. I will give a couple of examples for our home and community-based service waivers 18 and 20, which are services for individuals with brain injury and other related conditions. CMS required us to conduct full rate studies before they would approve those waiver services to be continued. I will also provide the example of 340B, which I believe all of you have heard a little bit about. CMS also has requirements for how we reimburse for drugs that providers are able to obtain through the 340B program. So, and lastly, quite recently, there are new regulations or new reporting requirements on the supplemental payments that state Medicaid programs often pay out to hospitals, with a lot more inquiry into the methodology for those payments and for the distribution of those payments. I raise this because CMS approval is a really important piece of what we do. It's also of great interest to all of you, especially from a budgetary perspective, because the federal government pays for the majority of main care services. Right now, under the public health emergency, most services get about 70% match from the federal government. During a non-public health emergency, it's usually about 2/3. So we have a bit of a bump right now. But if we do not receive federal authority, if we do not have a SPA approval or a waiver approval, that means that the state has to pay for the full cost of these services, which obviously can be quite a financial burden. I will just pause very briefly to see if anyone has any questions about the federal law and authority piece of the equation.
Yes, Senator Breen has a question.
Thank you, Mr. Chair. Just for the sake of sort of level setting, can you explain the term waiver service?
I can. And as follow-up, I can also provide some of the slides that I delivered as part of the orientation to HHS, recognizing that AFA did not receive that orientation. So there are certain requirements for state Medicaid agencies. For example, general requirements. For example, members need to be able to see any willing and qualified providers. A service has to be offered across the state as a whole. There are requirements as to how you pay for services. If a state wants to receive flexibility on any of those regular requirements, then you need to submit a waiver. Those waivers come with additional requirements. As I said, they often need to be cost neutral. There needs to be an official evaluation. Once approved, they're only approved for a set number of years, and then they need to be submitted for renewal. And so the waivers that you hear about most often in Maine are home and community-based services waivers. And those waivers allow individuals to receive services, special services in their homes that will keep them out of institutional care is the basic premise. There are other waivers. For example, with non-emergency transportation, we have a waiver to essentially have a little mini capitated managed care system for non-emergency transportation.
Thank you. Any other questions? I don't see any right now.
All right, so I'm going back to these words that I highlighted in the Social Security Act regulation. Efficiency, economy, quality, access was not mentioned, or it was mentioned actually. So efficiency, economy, quality, access, and the word that I added here is equity. Equity is not spelled out in the Social Security Act, but I think it's very important. When we have equity of payment to providers, that translates into equity in terms of access and services to members. So, economy and quality. As I said, I have a strong interest in value-based purchasing. And when we think about value, I think it's helpful for us to really take a step back and say, what do we mean by value when we talk about value-based purchasing? And I like the term value because it inherently is looking at both the economy and the quality piece of the equation that we're required in our rates. And so value is the relationship between quality and cost. You can, oversimplifying it, you can increase value a couple of different ways. If you are holding your cost standard, and then you can increase the quality of care that's provided. If you are holding your quality constant, then you can decrease costs. And so when we talk about value-based purchasing and how we pay for care, we're trying to move in the direction of making sure that we are incenting value. Having said that, over 75% of our current spend does not tie to quality or to value. It is paid out through fee-for-service or through cost reimbursement. So fee-for-service drives volume. When you're paid for 15 increments of something, you know you get paid more if you deliver more 15-minute increments. So that drives volume and that drives cost. So obviously there are other important incentives, including caring for patients, et cetera, that are certainly a piece of the provision of healthcare, but just the payment system itself is only set up to incentivize volume and therefore cost. There is no connection between the volume of services you receive and the quality of services you receive. We also know that there's no association between the cost of services and the quality of services. And so a fee-for-service system has nothing to do with quality, and it does not promote value overall. In addition to fee-for-service, another common payment methodology within Medicaid programs and within main care is cost reimbursement. It can be satisfying because with cost reimbursement, we actually get to see precisely where dollars are spent. And we know that we're not paying more than the cost of the service. However, cost reimbursement methodologies do come with other issues that we should all be aware of. For one, there's no reward to a provider for controlling costs. So as long as you are incurring the costs under cost reimbursement, as just a baseline kind of system, you are going to get those costs reimbursed. And so as a result, you could have two providers serving a very similar population, providing the same services, and those providers could potentially be getting very different reimbursement amounts if they are facing different costs. And so whether that's because of what they're paying staff or because of the rent of the building where they are, whatever the factor is, with cost reimbursement, there's no incentive to control the costs, and you're going to receive reimbursement that covers those costs. And so it may not be equitable. In addition to that, cost reimbursement in and of itself, like fee-for-service, there's no relationship between the payment and the quality of care. So with those two providers, same population, similar population, same services, receiving different amounts, we also don't know whether the provider getting more or less is the provider that's delivering higher quality care. And then I'll also mention that another downside of cost reimbursement is that it can be extremely burdensome and complex. I have heard feedback from the provider community to this point. Cost reports can be a painful process, and I can also attest that for state government and for the department, it is pretty amazing the amount of resources that go into administering very complex cost reimbursement systems. So instead of cost reimbursement, what is considered better practice is making sure that you pay out rates that are adequate to cover reasonable costs. By doing it this way, you're providing an incentive to be efficient and economical, because if you are able to provide the service at a lower cost than what that rate is, then you have some flexibility in how you can reinvest those dollars to serve the member population. Another benefit of focusing on rates that are adequate to cover costs instead of cost reimbursement is that it is fair and equitable. So if you have providers that are providing the same service, you know that they are going to receive the same reimbursement. So it's important when you are setting up these rates that are intended to be adequate to cover reasonable costs to make sure that they're doing a good job of covering those reasonable costs. And that's where the importance of the reimbursement methodology comes in. Oftentimes, the way that rate studies are conducted and rates are created is that you basically look at what the inputs are. Almost you can take a budget-based approach and you say, who delivers this service? How much are they paid on a median basis in the state of Maine? What are the staffing ratios needed for the service? What are the productivity levels, meaning how much administrative non-billable time goes into the service, as well as holidays and vacations, et cetera. Is there travel required? What are the costs of that travel? So all of that goes into determining what a rate is that should be adequate to cover reasonable costs. And there is concern sometimes that, unlike cost reimbursement, you don't know precisely where the rates that you're paying, where those dollars are going to the providers. This is where it gets important, again, to tie the reimbursement to actual quality outcomes. Because if you're tying it to quality outcomes, it's much more difficult for a provider, for example, to skimp on staffing because you know that it's going to have a negative impact on quality care. Another important piece of making sure that our rates are adequate are that we need to regularly review and adjust rates. If you don't regularly review and adjust them, then they're not going to stay adequate for long. We all know that. So how does MaineCare's current rate setting system compare to some of the principles that I've talked about on the previous slides? I will say that our rates are largely outdated. So over 40% of MaineCare policies, the rates do not have a regular schedule for review. Rates in almost 40% of MaineCare policies have not been updated since prior to 2015. This itself results in inconsistency. There's further inconsistency in that for services where we benchmark Medicare, and benchmarking Medicare is a very common practice because Medicare conducts rate studies like I described in order to ensure that their rates do cover costs. And so when there is a service within Medicaid that matches up to a service within Medicare, it is best practice just to benchmark Medicare and let the feds do some of the work of that rate setting for us. So we do benchmark Medicare, but the year that we choose to benchmark Medicare varies a lot and is not consistent. And then I'll also mention that in almost 30% of our sections of policy, we have what we will refer to as legacy rates where there's no methodology available. So we really can't say, are these rates adequate to cover costs, because we're not sure how they were set or if there actually was an underlying methodology. I mentioned Medicare benchmarks, and this looks like a confusing table, but I wanted to put it in front of you because I think it's pretty illustrative. So here are 3 different sections of policy. So there's section 55, which is lab services, section 90, physician services, and section 101, which is medical imaging. For all of these services, we benchmark Medicare rates. The policy is actually to benchmark the 2009 Medicare rate. So that's a pretty old rate at this point. But what happens for anyone who's been involved in healthcare is that every year, sometimes it feels like every month, there are new codes created and released by Medicare. And so there's a new covered service. And so we benchmark 2009, but then in 2020, there's a new code. There is no 2009 rate for that code. And so we then have to use that code and benchmark it to the 2020 rate. So what happens is that, for example, with lab services here, about 80% of the codes are from 2000 and benchmark 70% of 2009 Medicare. But almost 18% of the codes in that section actually benchmark a more current year. And so why does this matter? So I will say that for one, it's confusing. For two, it creates an incentive for providers to specifically look for codes that pay better and to provide those codes instead of other services. This does not happen all the time, but I will talk a little bit more about the stakeholder sessions that we had as part of our rate system evaluation. And I personally heard a number of providers who were saying that in order to have a successful business model, they specifically will look for codes that pay better and provide those services. So that's kind of skewing the services that are available in the state, because the decision is being made on the basis of what's the reimbursement for those services compared to other services, instead of the decision being made on what is actually needed to serve patients in the state. And I will also say that this creates more variation within services between codes as well as between services. And so again, has a detrimental impact on equity. All right, so in summary, the quote system that we have right now is very complex. It is very difficult to administer. It is difficult to navigate as a provider. It is confusing and inconsistent. And I will share that in this season, like many of my colleagues within state government, I've been reviewing a lot of LDs. And most of the LDs that I see that go to the HHS committee involve rate increases. And I do not think that I have yet seen an LD that calls for a rate increase where there is an actual explanation of the methodology or the math behind what that rate increase is. So I do not know if that rate increase would result in rates that are appropriate, that are economical and efficient and incent quality of care. I can also say, and I'll share some of this, that for a while there's been concern that we know that not all services have the same access to advocates and may not have the same ability to present their cases in front of the legislature. With the benchmarking report that I will talk about that we've conducted as part of this rate system evaluation, I can show you that there are services where we pay very little in comparison to other states and Medicare, and those are not always the services that that receive the same level of an audience or that have the same number of LDs that are addressing the rates that they receive. I will also just mention that sometimes the directive that we receive through legislation is not always consistent with our requirements for obtaining state and federal authority and the timelines to do so. that I referenced at the beginning of this presentation. And oftentimes it feels like my office is very much in reactive mode, and it is can be difficult to work on the objectives of our office and the department and the administration to proactively solve problems when you have a different agenda that is set for you. All right, so now I am going to actually talk about the rate system evaluation itself, but I will pause for questions before I proceed.
I don't see any hands up. Everybody's anxious to see you unwrap the package.
I'm a slow package wrapper, Senator Claxton, so. All right, okay, so our initial plan for the rate system evaluation. So in June 2019, the Health and Human Services Committee did request that the department report on its efforts to make the main care rate system more rational and transparent. Last January 2020, we issued an RFP seeking proposals to perform this evaluation. Our initial plan, frankly, was that we would have the evaluation completed in time for the department to review the recommendations and, as appropriate, integrate those recommendations into a budget proposal. Everyone knows what happened in 2020, and so like on many things, COVID had an impact on our timeline and the pace of our work, and so the timing was not ideal, but what happened is that the interim report that included recommendations could not be released until January. So I say this because my disclaimer at the outset of this presentation is that the recommendations you see are Myers and Stauffer's recommendation, and they're subject to the department's review. At this point, we have obviously not integrated these recommendations into the current biennial budget proposal because the timing did not work out, and also because we did not have those recommendations in hand to be able to determine if and to what extent they matched up with the department's priorities. So with that disclaimer, stakeholder engagement was a very important piece of this plan and of this work from the outset. We held 22 provider sessions. There were 3 sessions for members as well as a member survey. We had robust participation. More than 525 individuals and 270 organizations participated in one form or another in the stakeholder engagement opportunities that we had. We had 2 provider sessions. Well, we had many sessions, but we had the first session was October 5th through 9th and focused on hearing from providers in terms of the impact of how we pay for rates. The second round of stakeholder provider sessions was in December, and that round of sessions focused on the impact of the amount of the rates themselves, especially on ability to provide services to members. And the member session similarly asked members for their own experience accessing services, and if they had feedback as to how that access related to reimbursement rates, then we took that feedback as well. So the rate system evaluation deliverables fell into 3 main categories. The first deliverable was in November 2020, and when I get the chance, if it's appropriate, can share the link in the chat or otherwise where you can find all of these deliverables. The November 2020 report we refer to as the benchmarking report, and that looked at our reimbursement rates for all main care services and compared those rates with rates for similar services from select comparison states for Medicaid to rates for Medicare and to rates for commercial payers. That was the first deliverable. Second deliverable was in January, our interim report, and this was really where Myers and Stauffer laid forth, and Myers and Stauffer, excuse me, is the firm that was selected to conduct the comprehensive rate system evaluation. So Myers and Stauffer has laid forth in the interim report their recommendations for simplifying, streamlining, and making consistent our rate setting system. That report included a prioritization of services for rate review and also, where possible, estimates of associated investments that would be required to carry out those recommendations. That brings us to literally today. This morning, the final deliverable is being posted to our website, and that is the implementation plan. So the implementation plan took the prioritization of services from the interim report and now incorporates the department's recent, in progress, as well as planned rate initiatives and incorporates that into the prioritization of services for rate review. The implementation plan presents the recommendation for each service, the rationale behind that recommendation, estimated effective dates by policy section and service category. So I'll talk a little bit more in detail about each section of that report. So our benchmarking report. This resulted in 31 detailed Excel workbooks. So for every service category within main care, and we identified 63 service categories. Some of those align with a single section of policy. Some of those align with multiple sections of policy. You can access an Excel workbook where you can see code by code how the main care rates compare to Medicare, commercial, and rates from other state Medicaid agencies. I want to be really clear that I'll start out on what the benchmark report is. So it's really a cross-payer snapshot of how our rates compare. It is really to be used as an indication where further analysis may be required. Sometimes the services that Medicaid pays for are pretty straightforward, and we can say with confidence that we would expect rates to be similar to these other payers. And so in those instances, it's much more straightforward to say, yeah, we think we need an investment here, or we think there should be a savings. However, a lot of the services that we pay for are not that straightforward. The service model might be different than in other states. The population might be slightly different. If the service is dependent on minimum wage, then there are different economic factors at play in terms of whether a rate is adequate relating to state minimum wage law, et cetera. So what this benchmarking report is not, it is not a study of all the underlying rate assumptions and economic factors that go into the rates paid by different payers. So in order to really be a full and true and accurate picture to answer the question of whether our rates are adequate, there would have need to have been an in-depth analysis of the rate methodologies and economic context for all the other payers. And frankly, the scope of that kind of work would take too long and cost too much. So again, this is really intended to be a snapshot. And I will say that, again, especially for services where there's variations between states in terms of what the payment model is or what the service is, or those broader economic factors, this is not intended to be a judgment on whether or not current rates are appropriate when those services are more complicated. Again, it's really can be looked at as raising a flag for where we should do more study to understand whether or not a rate is appropriate. So like I said, there are 31 Excel workbooks with multiple tabs. And so this is obviously a very tiny little slice of the data. But what I am showing you here is just the service categories that came out at the top in terms of how they compare to the rates paid by other payers and those that came out at the bottom. So what we did in these workbooks was we determined a comparison rate. And essentially that was just an average of, we took an average of the comparison rates available. So when that included when there was a Medicare rate, we included Medicare in the average, and otherwise it looked at the 5 comparison Medicaid states, which were New Hampshire, Vermont, Connecticut, North Carolina, and Montana. And so we said, how does the main care rate compare to the comparison rate as a percentage? So the average percentage of the comparison rate. And so the 5 services at the top of this table are the services where there were the lowest relative rates. And so you can see that there are 2 categories of dental services: physical therapy, occupational therapy, and nurse anesthetist services. So for all of those services, we are coming in at about 50% of what we are seeing as rates for the other Medicaid states and for Medicare. So we're paying about half of what the other states in Medicare pay on average for those services. So, that's low. It goes without saying. On the bottom half of this table shows the services where our rates are looking higher in comparison to the rates paid by the other states. And so here you can see children's outpatient behavioral health services, home and community-based services related to supported employment, residential and day habilitation, and ambulance. I will say the benchmarking report for all these service categories also looked at the prevalence of what we called outlier rates. So where rates averaged either above 120% of the comparison rate or below 40% of the comparison rate. I want to point out here, so I said in the previous slide that this is not intended, especially for services that are more complicated, to be a statement on whether these rates are appropriate. And this is a great example here because for supported employment, residential habilitation, and day habilitation, we very recently just conducted an in-depth rate study of those services. And so we are confident that those rates are appropriate. You can see here that they look high compared to other states. But again, because we have done this study and we've looked at who provides the service, what are the minimum wage for individuals who receive wages at that level, and what are the other inputs, like we feel good about those rates and they are higher compared to other states. We could have further conversations about if we could incorporate different performance-based payment or different model structures, but we feel that these rates are adequate to cover reasonable costs for those services, even though they look high compared to comparison state rates. So before I move on to talking about the interim report recommendations, questions on the benchmark report piece of this work?
Yes, Senator Breen.
Director Probert, would you mind just repeating the comparison state names for me?
Yes, absolutely. So in New England, we had New Hampshire, Vermont, and Connecticut. And then we also had North Carolina and Montana. And I will say that there are actually a fairly limited number of states across the country that are fee-for-service states. I share that because managed care states, you can't find the rate information, so you can't do the kind of benchmarking analysis. So we, we're always interested in how we compare to New England states. North Carolina and Montana are also fee-for-service and have, undertaken some similar initiatives around value-based care and primary care. And so we're not saying that those states are perfect, but given that we had a limited selection of states to choose from, we thought that those were the best ones to look at.
Thank you.
Representative Fay.
Thank you, Senator Claxton. This is a lot to absorb, Director Probert, so thank you for taking the time to come. And this may or may not be the appropriate time, and if it's not, then I'll defer my question. But I'm just curious about when you're developing this methodology, if you considered workforce shortage and labor costs, and whether those were factored into these recommendations. And then the other piece of that is, in a lot of these categories, there's also out of pocket, sort of private pay. And I wonder how, whether the amount of that people pay privately for these services is factored into the benchmarking.
So those are excellent questions, and certainly important things to consider when you ask, why are we paying less or more than another payer is paying? The answer is that no, this did not look at those considerations, again, because just the scope of the report to look at every section and every and the vast majority of codes within main care and comparing those was very considerable. And so we did not have the resources to do an in-depth analysis of how does the workforce compare in other states, what are the minimum wage laws, and how does that compare to the services at hand, because not all services are sensitive to minimum wage. What are other payers paying in these other states compared to Medicaid? So those are all really relevant, great questions, and we're beyond the scope of this study. So this study, again, and this benchmarking report is not meant to be a recommendation. It is not saying that, we should go to the comparison rate for all these services. It's really, again, just a snapshot so that we can take this as one piece of information into consideration for where we need to do more work.
Mr. Chair, can I ask a quick
follow-up
on that? Yeah, thank
Please.
you. And I don't, this is something I don't need an answer to now, but I think what I'd like to know is what types of resources you would need to address those needs that you just mentioned, to get us back to, like, to consider it like baseline, right? Like, let's take a place where we are now and move forward. So I would be very interested in understanding what it would take to get that done.
Absolutely, and I'll be able to get to that a little bit further on in the presentation.
Representative Cardone?
Sorry. I think that Representative Fay was going in the same direction that I'm going in here. I'm not sure who set the parameters for this study and what it was supposed to do and wasn't supposed to do. But for me, sitting on the Appropriations Committee, I find this going to be minimally, if not at all, helpful to the decisions that I need to make. And I see you went back to the benchmark report slide. What I need is a study that is what this study is not, in order to make the informed decisions that I need to make as a member of the Appropriations Committee. I think Representative Fay was hinting at the same thing in terms of what the information that we really need.
Yes, I appreciate that comment, and the intent at the outset of this study was for us to be able to pinpoint the biggest problem areas where we need to do more in-depth studies per service. So if we had embarked on a study of each specific section of main care policy, it would take, I mean, as you say, it would be a 5-year process of going through all of those services at least. And we wouldn't have had any information to inform us as to what priority we should go in with those more in-depth studies. And so this is showing us, which I'll get to, a prioritization for what we should look at first. And I will say that there are some services where it is more straightforward. So you can see the services at the top of this table. It is not so complicated to determine whether or not dental rates, PT, OT, nurse anesthetist services, we don't need to do complicated rate studies for that. For those services, Medicare has rates, they do the rate studies, and it's pretty straightforward to say whether we're above and below and whether that's appropriate. So I'd say twofold. One is where the rates are more straightforward, this gives us a good indication of what would be needed to, as Representative Fay said, bring us up to baseline. And for services that are more complicated and require more in-depth study, this evaluation gives us a recommendation for, all right, this is what you need to look at first, and this is your priority order, which otherwise we wouldn't have had.
Does that address your question, Representative Cardone?
Yes.
Okay. Representative Madigan?
Thank you. Thank you for being here, Director Prober. I guess my question has to do with, you're talking about kind of whether the rates are adequate and how they compare with different states. I'm not quite sure whether you mean, are they adequate to pay for the providers paying for the service, or to solve the problem? In other words, are outcomes factored into this as well?
You're asking whether quality outcomes are looked at as a part of the analysis. So this report does look at where other payers factor in quality as part of their payment methodologies and makes recommendations for where main care should do the same, but it's not an analysis of the actual quality outcomes from these services across payers or in different states.
Thank you.
I don't see any other questions. Oh, yes, Representative Hymanson.
Yeah, thanks. Thank you for laying this out. I mean, you really understand what we've been going through in Health and Human Services with these rate reviews. I appreciate that understanding. When are you going to have another stakeholder meeting about this report?
That's a great question. So we have a main care advisory committee. That committee has a rate subcommittee that's been meeting on a monthly basis. At every main care advisory committee, we've been presenting on the progress and updates for the rate system evaluation. So that group has been getting those regular updates. We do not have planned a stakeholder session for the final deliverable that was issued today outside of our main care advisory committee meeting. We haven't been asked for that, but I would certainly consider that if that is of interest.
Can I just follow up?
Sure, follow
up. So, the Burns rate study that was done, what, 5 years ago now, that was thrown out because stakeholder engagement and input was not good and the output was not good. And the stakeholder engagement was not good enough. So I hope, have you looked, you know the history of the Burns and Associates rate study that was done, and because I think you still use some of those.
So I think that you are specifically referring to the Section 65 and the behavioral health rate study, potentially.
Yeah, well, they went through all, what you did, Burns and Associates did too, in a big study. And it was, it was thrown out because I think the stakeholder feedback was just blew up after the rates came out, and it was impossible to rein it back in. So we in HHS, got back to our usual rate study as a committee, which was 70% of Medicare, which is something that, you're correcting.
So Burns is another firm that conducts rate studies that are about for everybody, so we're on the same page, that conduct studies about the specific rate and rate methodology for a service. And main care is regularly contracted with them to conduct rate studies across a range of services. Sometimes we get very good feedback about a study that's been conducted. Sometimes we don't get much feedback, and sometimes we get very bad feedback. So I will say that Burns does have a pretty strict process for having stakeholder engagement, and have certainly pushed back since I have been in this position. Said to the department, we really think that this area needs to be increased and this area needs to be increased as a result of stakeholder feedback. And so they do incorporate stakeholder feedback into their recommendations. I was not here for the Section 65 study. I've heard that there's concerns around productivity assumptions, et cetera. And in this rate system evaluation, Myers and Stauffer does note where there were studies that were not implemented, and recommends that if those were not too long ago, that the department goes back and revisits those assumptions with stakeholders to make sure that the assumptions are appropriate. And if the service model has changed or it was too far ago, just to throw it out and start afresh.
Okay, thank you.
Don't see any other questions. So go ahead if you would.
Great. All right, so that was just the benchmarking report that we were speaking of. In January, Myers and Stauffer issued their interim report, including a number of recommendations for the system as a whole. You will find that a number of these recommendations are consistent with some of the information that I was sharing at the beginning of this presentation. And so it's important to use consistent and rational bases when you're developing and updating rates. It's important to use consistent Medicare benchmarks wherever they're available. The recommendation is to move away from cost settlement, also known as cost reimbursement. The recommendation is to move more payments towards alternative payment models, or APMs, and that's a term for payments that are tied to value, so that are tied to accountability for cost as well as quality of care. Just as an aside, I will share, and recently presented to Health and Human Services, that main care has a goal to have 40% of main care payments related to performance and quality by the end of 2022. So that's a goal we're very interested in and actively working on. Myers and Stauffer recommends that for services that require a rate study, which is basically services where there's not a good benchmark like Medicare or sometimes a commercial rate, that rate studies should be conducted at least every 5 years. And that on the off years from those rate studies, there should be an inflation adjustment every 2 to 3 years. And then for payments that do benchmark Medicare rates, for example, that benchmark also gets adjusted every 2 to 3 years. So you don't end up being in 2021 and referencing 70% of 2009 Medicare, that you should really be referencing a percentage benchmark of the current Medicare year, or at least close to current if you update it every couple of years. And then lastly, Myers and Stauffer also recommended that the department consider an advisory body of a sort to address special circumstances. So when something about a service has changed, or something about the larger economic context has changed, to have a body to kind of deal with those things that aren't going to be addressed through the regular schedule. I will say, though, that the importance of having a regular schedule and being on a schedule for when things need rate studies, when things need inflation adjustments, that solves a lot of the issue of rates becoming inadequate or misaligned with the service. And so there would be much less of a need for sort of emergency rate action if you can get yourself on a regular schedule to make sure that rates are appropriate and keeping pace. So for the slides that are coming up regarding the prioritization of services, those recommendations for the prioritization is really where the department is going to be taking a closer look. Myers and Stauffer doesn't know the universe of factors in terms of where we already have to adjust something because of a CMS requirement, or there's an emergency happening over here. And so there are other factors that the department and priorities that the department needs to take into consideration as we review their recommended prioritization for services. So today, I need to check back in with my staff, but this morning, the third deliverable, the implementation plan, is to be posted. And what the implementation plan does is it takes that initial prioritization from the interim report that Myers and staff are put forward, and it says, okay, let's take into consideration the recent actions from the department around rate initiatives, as well as those proposals that are in process or proposed. And so specifically, this looks at spring 2020 increases that were made across personal support services. It looks at rate adjustments that were made to home and community-based services, residential and day habilitation rate adjustments. That has been a process. Those rate adjustments started in early fiscal year 21, and we have one of our budget proposals is to wrap up that process of making sure that the rates are consistent for those services across 18, 20, 21, and 29. And so that would wrap up in July per our current proposal. Durable medical equipment. This is a savings initiative in the budget. We have been in trouble with CMS for a few years now because the rates that we pay for durable medical equipment, where Medicare pays for those same codes, we have been exceeding the upper payment limit. So Medicare has upper payment limits for certain rates, and if a state basically exceeds what Medicare pays, then for that amount that the state exceeds, the state has to forego federal match. So we are looking at adjustments for DME so that we no longer have that upper payment level limit issue. The implementation plan also takes into consideration the initiative we have underway that we have been calling Primary Care 2.0, but basically looks to combine a number of primary care related services within main care into a single consistent initiative that ties payment to quality and cost outcomes, and also changes the way that we pay for care to move away from fee-for-service. And then lastly, the other current department initiative that the implementation plan takes into consideration is our proposal to update children's residential PNMI Appendix D rates for the fall of fiscal year 22. So there are a lot of slides that follow. I'm not going to look at them in detail, but I wanted you to have them on these slides so that you could look at them more in detail afterwards. But this is, there's a much more detailed table than this in the implementation plan that looks at policy section, service category, details the recommendation in more detail than I've provided here, talks about the rationale for each recommendation, which I haven't included because it doesn't fit on the slide. It looks at the anticipated directional fiscal impact. So oftentimes if it's saying do a rate study, the fiscal impact is unknown. We don't know at this point. If it's looking at Medicare benchmark, for example, then it's much easier to predict what a fiscal impact would be. And then the implementation table also shows what year the work would start on a service and what our estimated effective date would be to implement the recommendations. So the report looks at services where we would start the work in fiscal year 22, services where we would start the work in fiscal year 23, and then state fiscal year 24 and beyond are combined. Also for those later services, we provide general information in terms of kind of the length of time that the different pieces of the process take in terms of rate study, federal authority, state authority. But as we get further out, we haven't provided specific effective dates just because it's hard enough to predict the future within the next couple of years, and getting beyond that just gets more imprecise. So that is the what is included in the implementation plan that's being released today. This includes some high-level detail. So for fiscal year 22, this is the priority order of services. I will say that in terms of the prioritization, and Myers and Stauffer talked about this in their interim report, they looked at, in order to determine their prioritization, they looked at best practices in terms of rate setting and how the rates in different sections of policy compare to those best practices. They looked at the results of our benchmark report. They looked at how long it had been since rates in that service area were last updated. They looked at our goal for alternative payment methods, so tying reimbursement to the value of care and seeing where other states might be ahead of us in terms of having those APMs where we may not at this point, and also took into account stakeholder feedback, especially in regards to adequacy of rates, but also in terms of administrative burden and other feedback. So some of the services that you see at the top are services where, while Myers and Stauffer did not say that we should bank on savings, that there was an indication that there could be savings, and they tried to give those higher priority status just in recognition that there's going to be needed investment in many services, and so trying to get some savings to then help feed into the investment would be helpful to the state. So you can see here that we lead with ambulance services. Specifically for non-Medicare services, the benchmark report showed that we pay a lot more than other states do for non-Medicare ambulance services. Targeted case management, again, there's more study needed because we look like we're on the high side. That may be appropriate. It may not. We need to do more study there. And then PNMI-E's, where we currently reimburse on a budget basis, and they recommend we standardize those. So I'm going to go a little faster just because it's too much to go into detail for each of these recommendations. So I'll just scan through so you can see. Dental services are right up there. This is one area where we do have a fiscal impact calculated. The recommendation is to actually, so Medicare doesn't pay for dental, so there's no Medicare benchmark. So Myers and Stauffer actually recommended that we look at the main health data organization's all payer claims database, and we use the commercial rates for dental services in order to set benchmarks. And so they gave us a range of investment that would be required. On the low end, if we looked at targeting 2/3 of the commercial median rate for diagnostic, preventive, and endodontic services, and then for all other dental services, we looked at 50% of the median, that would be an estimate of just under $9 million. That's state and federal dollars combined. If we wanted to actually benchmark the commercial median, so 100% of the median, that would be of an impact at state and federal dollars of $28 million. Priority number 5, this is getting at let's standardize what we use for a Medicare benchmark. So this looks at all these different sections of policy where there are Medicare rates available and says, let's look at the current Medicare rates and choose a percentage benchmark of those rates so everybody's looked at in mostly the same way. There recommendation said, so there are certain codes that were set under the Affordable Care Act that mostly go to primary care, and we're at 100% of those codes right now. So it said, keep those services at 100%, but for all of these other sections of policy, standardize at 71.4% of current Medicare rates. They came up with 71.4% because that is the rate at which none of these sections of policy would experience a net loss within those sections. So I say net loss because there are many rates with a big range of how they compare. No net loss means that within the section, there may be some winners and losers, but overall, that section of policy doesn't suffer a loss of payment. The 71.4% is the Medicare, is the percentage of Medicare where none of these sections of policy would experience a net loss. And in order to do this standardization, total state and federal costs would be 31 million. I will say that these are estimates that look at 2019 utilization levels. They look at 2020 rates versus the more recently updated 2021 Medicare rates. And again, they haven't done the analysis to see what the state and federal split would be in these dollars. So those would all be next steps that we as a department would need to look at and inform you of if these are to be translated into initiatives. So now I really will go a little bit faster. So this, so that was the end of the recommended services prioritized to start work in state fiscal year 22. And those services, we do anticipate that we could implement those recommendations by the end of the fiscal year. All right, so then it moves on to the work that would start in state fiscal year 23. You'll see that there's common themes of where there are Medicare rates. Let's benchmark those, even if we don't currently. This is where there's the recommendation to look at all of the community-based behavioral health services together and conduct rate studies there. Family planning, there are codes that actually align in terms of descriptions with certain Medicare codes, and so there's some benchmarking there that could happen. There's also the recommendation that we consider a kind of bundled clinic rate for family planning. Bundled rates are common to federally qualified health centers. And so that's something that Myers and Stauffer said that we could take a look at, and that would also be tied to quality of care. Freestanding dialysis, hospice. Hospice, there is a savings estimate there. We pay more than Medicare does for hospice services currently. Medicare also ties hospice services to a performance-based approach, and we could align with Medicare on that as well. We do not currently, so this would be about $200,000 in savings. Again, that's state and federal. And then we get into the hospital work where there's a lot of recommendations. To summarize, the recommendation is to make sure that payments are tied to accountability for cost and quality. The recommendation for critical access and some of the physician services is to move away from the cost settlement approach to prospective rates, where again, you determine ahead of time, this is the payment and that's what you receive without doing that settlement. We do align for acute hospitals with Medicare in terms of how they pay for inpatient and outpatient with different bundled payment amounts. We could use some updating to better align with Medicare in terms of how we do those payments. Let's see. There are psychiatric services. Sorry, I thought it was on this page, but maybe it's not. So there are services where we haven't standardized the rates we pay, for example, for psychiatric discharge. So there's a recommendation to do a rate study there and standardize those services. For our specific psych hospital services, Right now, we reimburse on the basis of charged amounts for inpatient services. And the recommendation is to, again, move away from it's kind of a hybrid of cost settlement versus a negotiated amount based on charges. So the recommendation is to move away from that, again, towards more standardization in how we pay for care. And I'll just note that the hospital work is large and would require some expert consultation for main care to get through that body of work. Similarly, our nursing facility services right now, together with our residential care facilities, are based in a cost reimbursement methodology that is extremely complex, complicated, error-prone, difficult for both providers and for the department. Myers and Stauffer recommends that we move towards prospective payments and away from cost settlement for those services as well. And again, make sure that we are finding a way to tie quality into the equation for those payments. So that caps out the work that would start in fiscal year 23. I'll just note that for the hospital work and the nursing facility work, we know that those bodies of work would take longer just because they are so complex. And so we do not have estimated effective dates for those pieces of the recommendation. And then we get into state fiscal year 24 and beyond. I will note that because we have really completed or will complete with our current proposals the rate standardization for personal care services, residential and day habilitation, and supported employment. This for SFY 24 is where you see the home and community-based services that tie into nursing services and therapies and clinical work, which also would be done in concert with home health services. And then at the end of the list are the services that we've recently updated. And so at the end of this priority table is where you get to, okay, now it's been about 5 years. And so this is when you rebase those rate studies over again. So I just have a couple slides left and then I'll stop. But just for an FYI, I did want to call out that Main Care does have a few other rate studies that are in progress right now. I already mentioned the PNMID Children's Residential Rate Study. That is part of one of our budget initiatives. We have a grant right now from the federal government called Support for Me, which is intended to do an assessment of capacity and gaps in care for substance use disorder services. And as part of that grant, we are doing a rate study for our PNMIB residential substance use disorder treatment facilities, as well as our substance use intensive outpatient services, just to see how those rates compare and what they should be. I will note that we do not have funding to implement the results, those pending results of those rate studies at this point. We are conducting a rate study where we have put forward a budget proposal, and that's for the mental health intensive outpatient services. So this is expanding eligibility for those services beyond the current SUD eligibility. And it's also, the rate study is looking at right now, in order to provide those services, providers really have to kind of take a piecemeal approach of putting together different services within Main Care. And so this rate study looks at restructuring that service model and having a payment method that will make it easier for providers and therefore for members to access these services. So that is another rate study underway where we do have a budget proposal affiliated with that work. And lastly, next steps. And so again, the department is going to be reviewing these prioritization that Myers and Stauffer has put forward as their recommendation, so that we can make adjustments as we see fit to say, okay, now this is the department's plan that will include refinement of fiscal estimates and updating and figuring out what the general fund portion would be for those services where we can come up with an estimate. Again, where there are rate studies necessary, we can make a very rough estimate before a rate study is completed, but it's really would just be a placeholder, and you'd need the results from the rate study in order to specifically say how much of an investment would be necessary. We also need to determine resources to implement this plan. In order to get onto a schedule of regular rate studies as well as regular inflationary adjustments and updating Medicare benchmarks, we need more staff to do that. And I think that it can be achieved with a modest amount of additional staff, but it does represent more work than our staff currently takes on, and they are fairly stretched at the moment. We also, because we have limited staff resources, we would be looking for expertise from consultants to conduct those more in-depth rate studies that are necessary to ensure that our rates are adequate and appropriate, and where possible tied to value. And so we will be looking at resources to conduct those rate studies as well. All right, I finished with 1 minute to spare, which I know is not a lot of time for questions, but I can certainly stay over if that works for folks.
Representative Hymanson.
Just two targeted questions. One is, in comparison to other states, what does our staffing look like? I've always thought of it to be very small staff compared to many other states. Is that true?
That's a great question. I know that Myers and Stauffer recommended that we add 2 FTEs for rate setting work specifically, but I'm not actually sure whether they came up with that number based on what other states have implemented or not. So I don't have an answer to that question, but I wish that I did.
And the other conversation, and I'm really looking for the department to direct the answer to this, and that is Medicaid managed care. Where would we, a conversation around that? When would that be advisable for our state, as opposed to creating this system? And
sure.
So, and gain and lose.
Yeah. So. First, I will make a general statement, which is that I have had conversations with Medicaid managed care companies in which they do talk about how the current rate infrastructure is an important piece of the work that they do and a consideration into whether or not they can achieve savings for a state. And so I have certainly heard the recommendation, and not just from managed care companies, that doing this kind of rate system evaluation is important if a state is to move in the direction of managed care. I will also say that most states, even if they do have managed care, they also retain fee-for-service services for a portion of their population. And so this kind of rate system evaluation is still critical for the fee-for-service population that remains. So that's my broad statement about how rates go along with managed care. In terms of where Maine is, in terms of considering managed care as an option, I will say that last spring, so a year ago, we were actually kicking off a project to do a close look at what the options are for Maine. It used to be pretty black and white that you had managed care and you had fee-for-service, but now there are a lot of other options with value-based purchasing, and you have some states that just take a value-based purchasing approach, looking at accountable care organizations. You have some states that have managed care / ACO hybrids. You have states, obviously, that are just doing managed care. And so we had set out on a project to really look at the continuum of models that are out there, to have a discussion with stakeholders, including the legislature, about the factors in Maine and what would be the desired approach for us. As soon as we kicked off that work, the pandemic hit, and nobody could have those conversations at that time. And we also recognized that it was a funny time to have that conversation, because the benefit of not having managed care when you're in a pandemic is that you don't have dollars tied up going to managed care entities that you can't do anything about. So we actually did have flexibility to be able to adjust rates where appropriate, and also where the state budget as a whole could benefit from some reduced utilization. States that were doing managed care did not have that benefit. And that's not a reason to not do managed care, assuming that, we're not going to be in pandemic status on a regular basis. But it is difficult to make those decisions when you're in that context. And so we decided instead to work on how to improve our value-based purchasing initiatives and bring more accountability from providers into that work as a first step, instead of taking on the larger managed care question at that time. And I did present to Health and Human Services about that work that we did around our glide path towards more accountability for value-based purchasing. So I'm happy to talk more about that at another time.
Thank you. Just one follow-up, if I could. The value-based reimbursement, the jury's still out. I mean, everything I've been reading about outcomes for financial success have not been terrific. So I wondered what you thought about the models that are out there and how successful they've been in terms of financial gain.
So I think there is a lot of variation.
That's a big question. That's a big question. I think to do it justice, we ought to invite the group of us to sit down together again, because they've laid out some very expansive plans around value-based purchasing in HHS that she could share with everybody. But I'm not sure we can get that answered in a short time frame, because I think the issue is also there for managed care. In terms of the jury's still out.
Yeah, no, I appreciate that. I think I'm just, introducing that as a way to say the history of value-based care is not as set as we'd like to do. So I just don't, want to move from one to another and get the problems of the other.
Bring them with you. Okay. Representative Lemlin had a question.
Thank you, Senator. My question is with the DME equipment. You stated that the CMS has an upper payment limit, which you can't go over. What do you do in the case where the upper payment limit that CMS offers is below the actual cost of the product? Because if it is, and I know many cases where they are, it's just like the person not being able to get that DME equipment because the pharmacy will not, is not going to give it out for free.
That's a great question. CMS does conduct rate studies to set their rates. However, I imagine, and to your point, there's variation in across states in terms of what the actual costs may be, especially if you might not be able to benefit as much as from economies of scale, et cetera. So all I can say is that the bottom line is that if we pay above the Medicare UPL, then we need to pay with all state dollars. And so that is the trade-off from the state perspective. Otherwise, we have staff in main care that work closely with providers and with members to try and ensure that they get the equipment that they require, which sometimes is a challenge. But we're a little bit between a rock and a hard place with that question, because if the Medicare rate is below cost, well, I'd look to lobbying Medicare to update their rates. But if we go beyond it, we have to pay with all state dollars.
Is that a rolled up rate, the UPL, or is that specific to each item of DME?
They do a crosswalk code by code.
Okay.
Yep.
All right. Thank you. Representative Millet, I'm sorry.
Thank you, Mr. Chair, and thank you, Michelle, for a very comprehensive presentation. I like the way you outlined in the last portion the implementation plan by priorities and by fiscal years. I was just curious as to, over and above the durable medical equipment, upper payment limit, and the asterisk mental health intensive outpatient Section 65 category, where you previously alluded to adjustments within the current budget. On those top 5 priorities that would be completed during fiscal 22, would you anticipate being able to make those adjustments during the second regular session while we're in mid-biennium form, or would those likely be delayed until the 131st legislature comes in and we're dealing with a fiscal 24-25 biennial budget? Could you comment on the timing when the adjustments might be ready for budgetary consideration?
So my answer will probably not be entirely satisfactory. What I can say is that we are prioritizing that conversation within the department. So one, to determine if, if we want to, whether we want to adopt Myers and Stopper's recommendations for prioritization, or if we think that there should be any changes to that prioritization, and then to determine whether it's appropriate to try and integrate those efforts into the supplemental, or if we have to wait. So I don't have an answer yet, but we are actively trying to come through the answer to those questions.
Thank you.
Representative Arada had her hand up. Do you still have a question?
No, I don't. Thank you.
Okay. Representative Fay.
Thank you, Senator Claxton. I guess it's sort of 2 questions, but they're really intimately related. And you at the beginning of your presentation, or in the end of the presentation around what the priorities were, you talked about Section 1969 and 63 having gotten rate increases. Now, I guess I'm confused because you said they were in a current rate study. So you're doing a rate study now, and then you're going to prioritize them. I mean, they're going to that sort of the back of the line. So I just want to understand which thing is happening so that I can square it in my head. And then kind of intertwined in that is a question about what I think I asked it earlier, like what other payers are paying for PSS and ISS and personal care. And then, was there any conversation about equity and access when you were talking about how to prioritize which sections are going to be prioritized for rate studies? So for instance, I know that there are some sections that have just huge wait lists. For instance, homemaker. There's 2,000 people waiting for homemaker, and part of the reason is we have a workforce shortage. So if we're not thinking about how to incentivize more people to join that workforce as we're coming up with payer models, how does that help with access and equity for those folks who are on the wait list? So it's a complex question, and it may take an answer that bigger than this forum here, but I'd really like to understand how all of those pieces have come into the design here.
Sure. So, sorry if some of the talking points got confusing. So I will say that with personal care services, also sometimes referred to as personal support services, in last spring of 2020, we implemented earlier than initially planned due to the pandemic, updates to the rate study to ensure that the rates for all of those services were targeting the appropriate median wages and salaries for all the different positions that provide those services, and it also had updates for inflation, et cetera, et cetera. So in spring of 2020, across personal care services, the rate increases averaged between 23 and 30% increases, depending on the specific service. And so that work has really been conducted and was implemented in 2020. And so per the recommendation of Myers and Stauffer, it would be 2025 to look at those rate studies again and update them. With the recommendation in the interim being that, between 2022 and 2023, those services should get an inflationary adjustment in the interim before you look at doing a rebasing of the whole rate study as a whole. And so that work has recently, for personal support services, been implemented. And for that reason, for those services, they are at the bottom of the priority list, because the next step is really to adjust for inflation and to rebase, which is going to be the recommendation for all services moving forward. So like once you have the rate study to say this is what the rates should be, then every 5 years you rebase with a rate study, and in the interim between 2 to 3 years you do an inflation adjustment. In terms of your question as to what other payers pay for personal care, so I pulled up one of the benchmarking spreadsheets, and you can go to our website and you can look code by code at how those different services compare to other payers. I can just read off here that main care rates for personal care services average about 105% of the comparison rate, and that comparison rate looks at the 5 states that I mentioned as well as Medicare. So we're slightly above average in terms of what we pay for comparison for personal care services overall. And then in terms of your question as to whether we account for access in the prioritization of services, we did take into account feedback that we received regarding member access to services, including wait lists, and Myers and Stauffer did account for that in their rationale for different recommendations. So that was noted. But I can't say specifically whether or not, for example, wait list for homemaker services was raised as an issue or incorporated into the recommendation. But we do have transcripts of all of our stakeholder sessions, and the answer might be there somewhere.
Thank you. Yeah, I'm sorry, just Senator Claxton, just a quick follow-up, and thank you for that, Director Probert. I just would urge you to, and I think it was alluded to earlier, to maybe have, from Representative Hymanson, to maybe have those post-report stakeholder meetings, because and I think you know this, that my concern is really that we have a significant worker shortage in this area. And if we're not taking that into consideration when we're making these rates, and I don't think the worker shortage is going to get any better in 5 years, that it's going to be really problematic for the folks that are receiving these services, or even more problematic for the folks who aren't receiving these services who are eligible.
Senator Breen, did you have a question?
Thank you, Mr. Chair. I do have one discrete question that probably it's just more of a list. And that is, can you get me a list of behavioral health services that have closed in the last 24 months, either closed or had to relocate individuals to services out of state because the service is no longer available in Maine. So that's one question for later, obviously. And the second one is a larger one that I want to say, with the utmost respect for your expertise, Director Probert, in all this policy and all the, let's say, the parameters in which you do your work, which we don't set, but I think, having chaired the mental health working group last year, last session, we got one of the things that came from the Office of Behavioral Health was a pyramid of services. And I guess what I'm still waiting for, and obviously the pandemic has been an enormous challenge, and I give you a lot of space and room for that, and I don't mean to underestimate that, but I guess what I'm still waiting for, and I'm trying to figure out whether we need legislation to do it, is a vision of, what the Mills administration wants to do to address the mental health needs of Maine people, and how to pay for that and how to staff it. And there's nothing in what I see today that gets at that. And again, I'm not trying to diminish the amount of work that's gone into what you're doing, because I know it's enormous. And again, it's in a framework that we don't set. But I wonder, and maybe this is something that obviously Molly Bogart can help me get to, but if there is a long-term strategic plan for mental health services in the state of Maine that's in the department someplace, could you get it to me? And then secondly, how can we move this debate forward in a more global sense so that we can say, this is how this department plans to address mental health. Here's how we're going to staff it, and here's how we're going to pay for it, from community level warm lines and phone service all the way through inpatient hospitalization and that whole continuum of care. So I know you're not going to answer that today, but I want to invite you, request, put it out there so that this legislature can make some headway on that. Thanks.
So I'd invite Molly to share any of the questions that the department ends up answering with all of us who are on the call today. So Representative Millet, did you have another question? Okay. Senator Baldacci?
Thank you, Mr. Chairman. Director Probert, thank you for your comprehensive report and for all your work in this important area. One of the concerns, I kind of want to echo what Representative Fay and Representative Hymanson have talked about. I've worked with families who have children who are severely disabled, and trying to obtain the personal care services has been a very frustrating and difficult episodes that have taken a long time. And I've dealt with the department previously on issues like this in terms of how they are trying to fix the shortage, but there's really no fix to that shortage. I really think that there has to be a separate effort on this issue, because I think that there are hundreds, if not thousands, of situations where people are waiting or families are waiting. And oftentimes a family member has to quit a job to take care of a severely disabled child. I think that there are situations where they're waiting a long time to find somebody. So I think that there has to be a separate, specific focus on this issue. My understanding, Director Probert, is that these rate increases from last year were temporary at the time, or they are permanent.
The personnel support service increases were permanent. They were not temporary.
Okay, and did you notice any substantial change in the is there a lessening of the labor shortage since that happened?
Things are very confounded by the pandemic, and so it's really difficult to look at rate increases that happened at the same time as a pandemic and to say what impact those had on the workforce. It's a difficult, important but difficult question to answer.
Yeah, no, I totally understand. But my previous work with these families, what I saw was that these personal care attendants could get better paying jobs at a number of other places that were less demanding. I think that we need to have a separate focus on how to resolve this labor shortage, because it's not just a numbers issue for people. This is heartbreak and it's emotional pain, economic pain as well for these families. And at some point we may have to consider, actually, instead of trying to rely on in addition to private agencies, we may have to have the state train people to do this kind of work and become permanent state employees in order to have a stable situation. But I really think there needs to be a separate focus on this issue, because I would like to see some resolutions, some improvements in this area. That's why I've supported rate increases for direct care workers and why they need to happen. But I really urge you to try to look at this, and other policymakers to look at this as a separate issue from your typical financial issues. So I appreciate your time and look forward to working with you. Thanks.
Thank you, Senator. Representative Craven.
Thank you, Mr. Chair. I have two little short questions. One is whether, when you're doing the evaluation, whether minimum wage was considered across states. And the other one is, I would really like to know whether folks waiting in the Section 21 on the Section 21 waiting line are actually being placed, whether providers are even able to provide the service.
You're absolutely right, and I remember it.
Could we mute everybody?
So I would just like to know if people that are waiting on the Section 21 waiting list are literally being placed in placement. Thank you.
Okay, I have two questions again that wouldn't need to necessarily be answered today. Mine were about how much of the current year's initiatives are built into the budget already, and whether any of this represents new money that you'll be looking for, since you're focusing on some of the folks who aren't getting paid as well early on. And in the work with the PNMIs, is the progression to the QRTP status being recognized in that payment model? So those are my two questions. Are there any other questions? Go ahead.
Do you want me to answer now, or?
Sure, if you can. Yeah.
Okay. Yes. So I can say that in terms of the current budget initiatives, what is reflected that I talked about today in those initiatives, one is the PNMI Children's Residential, which is looking at the cost of meeting the QRTP, the Qualified Residential Treatment Provider certification. In addition to the PNMID, the budget initiative looks at completing our process of standardizing the rates for residential and day habilitation in sections 21 and 29. So we started that process last year, but that looks at sections 18, 20, 21, and 29 and is making sure that all of those rates are updated according to the rate study that was conducted. Also under section 21, it looks at the waiver home rates specifically to adjust those as appropriate to cover wage costs. So that is what is included in the current budget proposal, along with the mental health IOP work that I mentioned, and the savings initiative for durable medical equipment because of the UPL issue.
Yep. Thank you very much. Are there any other questions before we go? I don't see any. So again, thank you, Director Probert, for being here. We'll look forward to regular updates as to progress. We'll look forward to Molly's sort of summative answers to the many questions been asked, and there may well be other opportunities for the two committees to sit down together and talk about some of the broader topics. So we will do that down the road. So thank you again for being here. I think what I will do or recommend for the HHS committee is that we take a 5-minute break. This has been sitting too long. And I'm going to turn the chair over to Representative Meyer so I can go to another committee. Good to see a lot of familiar faces.
Thank you for your time.
Take
Thank you
care.
for having us.
Waiting for some of our HHS members to return from a short break. Welcome back to our late morning activities here on the Joint Standing Committee on Health and Human Services. This morning, we have several amendment reviews and some reports, and I will turn it over to our analyst, Anna Broom.
Hi. So we do have one piece of the budget we need to straighten out just a little bit. Do you want me to explain it, Luke, or would you like to do that? It's related to the case workers that would be starting 3 months early.
So I can explain that, Anna. So what I really want to do is just let you know exactly what the cost of that change is. The department did provide me the information, so I know exactly what that increase will be. And I also want to note that because of how it was voted, the addition of those 15 caseworkers, that initiative, which was lines 82 through 84, was voted in unanimously. So that is staying as a line in as proposed. What I'm doing is I'm adding essentially new lines to Part A that would pay for this additional 3 months of these 15 caseworkers. That's just to make it, I think, a little easier when AFA is reviewing the report back and trying to understand what's going on. But I just wanted to let you know the total cost. And obviously it's only in state fiscal year 22 because it's adding the 3 months just at the beginning. And personal services and all other, the total cost is $387,589.
Could you
Questions
repeat
for
that
Luke?
amount?
Sure. It's $387,589.
Any other questions? Seeing none. Go ahead, Representative Perry.
Thank you. And I'm just trying to review where we were. When we talked about having the hiring occur in October, that's the increase that you're talking about, right?
Correct. Correct. It's to have all 15 positions begin on October 1st, 2021, as opposed to January 1st, 2022.
Okay, great. And I know that was something the department had suggested anyway, right? Right.
Yes.
Good.
Yeah, Molly suggested that yesterday.
We think that you need to vote this. That's why we're
I'm
bringing
sorry.
this up. That's okay.
Gotcha.
I don't think anybody realized. I'm sorry, Representative. We weren't very clear.
No problem. So I would entertain a motion.
I would so move.
I second.
Go ahead, Carrie.
I'm sorry, Representative Meyer. Looks like Representative Perry has a question.
I'm sorry. Go ahead, Representative Perry.
Sorry, another question. Are we re-voting the 15 because they're being in earlier, or is this just an increase within the initiative?
This is to add what is essentially a new initiative. It links to those lines, but it's a brand new initiative in Part A. That's for that $387,000 for just those 3 months of funding.
Thank you.
Any other questions? Seeing none, go ahead, Carrie.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton. Senator Claxton is absent. That's 10 yes, 3 absent.
So that's all we have for today for this particular topic. We will revisit the one last amendment related to domestic violence on Thursday because we don't have all the information or the people available today. So if it's okay with you, I have a couple of amendment reviews to do that should be very straightforward. Okay, so I have to share my screen for them. So the first one is, hopefully you can see that this is Representative Craven's bill related to donor breast milk. So this looks like a lot of language, but I just want to let you know this is what it will look like in the end. This is, if you will have to cast your mind back a month, this is because the department asked for the same amendment that you passed last time. So although this looks like a lot of language, it's actually already been ticked and proofed because it was done 2 years ago. So this is an exact rerun from before. So this language is easy, and this was according to the department. This was a unanimous report. The piece that I do want to show you that goes with it is the fiscal note, and that is here. So this will be the also on the bill. This is no surprise either. And Luke is probably still here if you have any questions as well. So this is the section that will go onto the bill with 157,000 in general fund plus matching fund because it's main care, and this will send it to the table. And this was also no surprise. So unless anybody has an objection, that bill is ready to go. Okay, so then I have one more, and this is, I have to go back to my fiscal note. Can you see that? That's LD 93 childcare. Did that show up correctly on your screen?
We can see it.
Oh, good. Now, if I could just get it to move down. Why won't it move down? Oh, there we go. So this is also a unanimous report. This is the department bill where they're moving from the 4 steps to the 5 stars. And this is a strike and replace only because it's easier to read this way. So what you decided to do, instead of using a minimum of 3 steps, was to allow the department to just make their own, the rule is still required, it's here at the beginning of the paragraph requiring rules that adopt quality differentials. And so the easiest thing is you just literally strike out the entire sentence. So that's also of no surprise, but I wanted you to see that that's how it would look when it comes to your desk. And then the no fiscal note that Luke confirmed. So that means that it just stays looking like this. So this is a nice, easy one for you, or nice two easy ones for you to review. So those are good ones to begin with. So that's what I have for today. I do believe that Representative Javner has a report. Is that correct, Representative Javner? Yes. And then you will be done for the day.
I'm going to grab it.
Thank you, Anna. Take it away, Representative Javner. I don't know if we have just lost Representative Javner. There she is.
I'm back. Sorry, I had to get my report out of my bag. All right, so I had the Maine Vaccine Board report, September 22nd, 2020. This is the 10th anniversary, the edition of their report. So they contracted the firm Barry Dunn in order to complete their report for them. The history of the Maine Vaccine Board was established in 2009 with the goal of expanding vaccination access for Maine children. The board oversees the Maine Universal Childhood Immunization Program, which is a mechanism for the state of Maine to purchase all childhood vaccines for children who are not eligible for the Vaccines for Children program and distribute them free of charge. So the Vaccines for Children program, or the VFC, is an entitlement program for eligible children age 18 and below. So the VFC helps families of children who may not otherwise have access to vaccines by providing free vaccines to doctors who serve them. This is administered at the national level by the Centers for Disease Control through the National Immunization Program. The CDC contracts with the vaccine manufacturers to buy vaccines at reduced rates. Children who are 18 years old or younger are eligible for the Vaccine for Children's vaccine program if they're eligible for Medicaid, if they have no health insurance, are Native American or Alaskan Native, or have health insurance, but it does not cover immunizations. The Maine Vaccine Board determines the list of the childhood vaccines available in the MUCIP, which is the Maine Universal Childhood Immunization Program. That's a mouthful. They also facilitate universal purchasing of vaccines with the Maine CDC to purchase vaccines at the lowest possible cost. So I don't know if you really caught it. It was kind of confusing. I apologize. I'm going to backtrack a little bit. So the Maine Universal Childhood Immunization Program is different than the Vaccines for Children program. So we have the Vaccine for Children program, which covers a certain segment of children, and then the Maine Universal Childhood Immunization Program, which picks up the rest of the children that may not be covered by the first one. So the MUCIP purchases vaccines from the CDC at a cost per dose that is less than private payer rates. So from April 2016 to March 2020, the annual savings ranged from 20 to 30%, averaging approximately $4 million per year over the 4-year study period. These savings accrue to the payers, which lowers the rates for purchasers of health insurance. Funding for the MUCIP comes from the Vaccines for Children program and an assessment on health plans, insurers, and third-party administrations. As I mentioned, the Maine Vaccine Board engaged Barry Dunn to provide an impact analysis of the MVP and its funding of the MUCIP. This report reflects an assessment of the MUCIP's impact since its inception and identifies opportunities for improvement. To conduct its assessment, Barry Dunn, number one, solicited stakeholder input by surveying insurance carriers, pharmaceutical representatives, healthcare providers, a public health representative, and a representative from the state of Maine. Number two, they reviewed the Maine statutes and other relevant information about the MUCIP. 3, they conducted a literature review and national scan of other universal child vaccination programs. 4, they collected and analyzed the data provided. So the cost of savings over time, every April 1st, which is coming right up, the CDC increases its cost per dose for childhood vaccines. Increases are due to increased cost from vaccine manufacturers. Barry Dunn reviewed 4 years of the CDC fiscal years to observe the cost savings. In 2016, there was a 27.8% savings. And in 2017, 24.7% savings. And in 2018, a 24.6% savings. And in 2019, a 20.5% savings. The Maine Vaccine Board program efficacy, providers can receive state-supplied vaccines at no cost. Children have improved access to vaccines, and all payers participate in an efficient, cost-effective system for purchasing and distributing childhood vaccines. Providers have a single source for vaccine supply. Opportunities for improvement. Number 1. Greater promotion and education regarding the Maine Vaccine Board. 2, an extension of program to adults. 3, the need to cover cross-border children, such as if you live on the New Hampshire border, to cover children that receive services in New Hampshire. Although vaccination rates should not be used as a measure of the MVB success, a response to the survey performed by Barry Dunn from the pharmaceutical industry expressed a concern that universal purchase programs have not demonstrated an increase in vaccination rates with the use of assessments for vaccine purchasing. In conclusion, while the MUCIP was not designed to directly impact vaccination rates, it has improved the vaccination access and efficiency and has reduced cost for providers. The evidence and data gathered during the course of the study supports that a decade after its legislative enactment, the MVP has created an efficient and effective mechanism for children to receive and practitioners to provide vaccines in Maine. Oh, you're muted, Representative.
Thank you. Thank you very much. Well done. Any questions for Representative Javner? Seeing none. Did we have anyone else on the list today? No, that was it.
I don't. There could be volunteers I'm unaware
Okay.
of, but I don't.
Do I see any volunteers here to provide? No, I see none. I see Representative Perry laughing. Well, we will circle back to complete our reports as we move along. Nothing else is on our agenda for this morning. We will break until 1 p.m. When we'll reconvene for public hearings on LDs 559, 590, 624, and 699. So I will see the committee back here at 1. Good girl. Good afternoon, Representative.
Good afternoon.
Hello, Representative Craven and Senator Moore.
It's a sunny day here in paradise.
Still a bit chilly out there, though.
It is. I walked between the Cross Building and the State House, and it was still a breeze.
1, 2, 3. Any other additions, Carrie, to the list other than Representative Grohowski?
I'll check again.
Thank you.
No additional signups, Representative Meyer.
Thank you, Carrie. It looks like we have a quorum and a senator. So it's 1:01. Should we get started? All set? Good afternoon and welcome to the afternoon session of the Joint Standing Committee on Health and Human Services. We are assembled around our virtual horseshoe and we are live streamed on the HHS channel found on the Maine State Legislature's YouTube channel, where you can find the replay of our proceedings should you miss us live. This afternoon, we'll hold public hearings on the following bills in this order: LD 559, 590, 624, and 699. For those testifying, please ensure the name you're using on the Zoom webinar matches the one you used when you signed up to testify. And we would ask that in order to help our clerk manage the attendee list, you exit the webinar once you've finished your testimony and answered any questions from the committee, and watch the rest of the hearing live on YouTube. We'll be taking testimony in the following order: the sponsor, any co-sponsors or other legislators providing testimony, those offering testimony in favor of the bill, then those opposing the bill, and then finally, any neither for nor against, but with additional information for the committee. We do run a 3-minute clock on testimony, and you'll receive a prompt when you have 30 seconds left, and we would ask that you bring your testimony to a close at that point. Public hearings are just that, for the public. The process of hearing testimony certainly engenders and encourages probing questions, and the committee is asked to use the raise hand function in order to ask those bill-related questions. We will do a quick round of introductions around the horseshoe, starting with Representative Zager.
Thank you, Madam Chair. Good afternoon, everyone. My name is Sam Zager. I represent District 41 in Portland.
And Representative Lemelin.
Good afternoon. Thank you. My name is Michael Lemlin. I represent District 88, which is Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good afternoon. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, West Port Island, and part of South Bristol.
Let's see, Representative Perry, Representative Griffin.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Candace.
Representative Connor has another committee obligation. Representative Craven.
Thank you, Madam Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
And Representative Madigan must be away from her desk. Senator Moore.
Good afternoon. My name is Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
And Representative Javner must be away from her desk. I am Representative Michelle Meyer. I'm the House Chair, serving District 2 in Southern Maine, which is Elliott, and parts of South Berwick and Kittery. With that, I will open the public hearing on LD 559, which is, bear with me for 1 second while I find our agenda. Yes, 559 is an act to improve the rights and basic protections of persons with acquired brain injuries. And I would welcome Representative Allison Hepler, the bill's sponsor, to provide her testimony. Good afternoon, Representative Hepler.
Good afternoon, Representative Meyer, and esteemed members of the Health and Human Services Committee. I'm Allison Hepler, and I represent the towns of Arousic, Georgetown, Pittsburgh, Woolwich, which is where I live, Dresden, and part of Richmond. And I'm pleased to present LD 559, an act to improve the rights and basic protections of persons with acquired brain injury. In 2011, the 125th Maine legislature passed LD 1196, which defined acquired brain injury and directed the Department of Health and Human Services to identify and ensure the rights of patients with acquired brain injury. Despite this important step to make sure that providers recognized rights to treatment, protection, and health and safety, the Maine Attorney General's office has indicated that this law is insufficient to ensure that people with ABI will receive the same rights as people with intellectual disabilities or autism. And these include things like rights to dignity, privacy, and humane treatment, religious freedom, voting, communication, fair wages and hours, and medical care, to name a few, and the same rights of appeal. And in fact, LD 559 would also have the same right to appeal or to grieve a decision that the department or a provider has made on their behalf. The bill would also create a task force to build rules and procedures related to people with acquired brain injury. Others here today will speak with more experience on the nature of these rules, as well as the experiences of providers and clients. But it's my understanding that creating rules specifically on behalf of people with ABI would not constitute a major overhaul of existing rules to serve along with those with intellectual disabilities or autism, but that there are some specific differences. So why is it needed? It's a question I always ask when I'm in my committees. As previously mentioned, there's a gap in the statute regarding people with acquired brain injury, but providers also need more defined rights that apply to their patients so that it's clear what care is provided. In fact, providers already deal with clients who do have ABI, so having these rights and pathways to appeal will result, spelled out, will result in more clarity and efficiency for all parties involved. While these rights seem like a common sense thing to do, it's also personal for me. 23 years ago, my first husband suffered a traumatic brain injury after what would become a fatal workplace accident. Had he survived, I would have needed every possible service available. As a full-time worker, I'd be relying heavily on these services since it would have been impossible for me to provide full-time care myself. While I like to think of myself as someone who would be able to navigate a brave new world to avoid, on behalf of my husband, it'd be crucial to know that protections were in place to avoid inadvertent harm being done to him or any other person in a similar situation. And for family members with fewer resources than are available to me, it would be even more important. Providers, patients, and their loved ones tell me if you've seen one brain injury, you've seen one brain injury. This is why this bill is needed, namely to provide more specific guidance in order to protect and advocate for people with acquired brain injury. Thanks for your time and attention, and I'm happy to answer questions as I can.
Thank you very much, Representative. Questions for Representative Hepler? Seeing none, we thank you for being here today. I see Representative Madigan. Would you like to introduce yourself?
Hi, I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Thank you. Representative Nicole Grohowski is here as a co-sponsor. Welcome.
Thank you. Good afternoon, Representative Meyer and members of the Committee on Health and Human Services. I'm Nicole Grohowski, and I represent the communities of Ellsworth and Trenton in the Maine House. I appreciate the opportunity to speak in support of LD 559, an act to improve the rights and basic protections of persons with acquired brain injuries. Now, those of you who are astute at checking all the testimony coming in on the internet, you'll see that I myself have not submitted written testimony. I am a huge fan of submitting written testimony, but today, instead of writing about my thoughts in this, I have come to read to you testimony submitted by a constituent who has been suffering with an acquired brain injury for years, and I've been working to try to help her get the resources that she is entitled to, and we have had trouble. So I wanted to come and share her experience and her words with you because she is at a doctor's appointment today. So thank you, and I would refer you to the testimony of Nadine Lewis if you would like to read along. She says, I want to thank the sponsors of LD 559. As an acquired brain injury survivor, I completely understand the challenges that go along with this gift. I call it a gift because according to statistics, I shouldn't be here, and it is a blessing that I am. This gift brings many challenges, and one of them is the lack of understanding by people that have not experienced the same fate. That is why I think this bill is so important. I want to explain how the ruptured aneurysm I experienced at 49 years of age on the evening of February 18th, 2010, changed not only my world, but shook my family's world to the core. My 12-year-old son and his friend were sitting in the living room with me when the hearing was sucked out of my left ear and I fell over on the couch unconscious, defecating, urinating, and vomiting involuntarily. These children suffered serious trauma from this event, both short and long term, and I did too. The mother, sister, daughter, grandmother, and friend they all knew survived, but was vastly different. After having to see her with tubes coming from her head and asking the same questions over and over for 3 weeks, she had to have another surgery to have a shunt installed to remove the blood from her brain so she could become aware of what was going on. Her brain was in a type of functioning amnesia, and of course she didn't know it because she was functioning, but was in a blackout without any functioning memory at all. Slowly she became aware, but the frontal lobe of her brain was damaged. Part of the woman she once was gone. After 3 weeks of physical, occupational, and speech as an inpatient at Spalding Rehab in Boston, she was released to go home to an apartment in Maine alone, without any supports whatsoever. I believe this was allowed to happen because of the lack of services and education about acquired brain injuries here in Maine, especially. I've come a long way since that day in February 2010 on my own accord. There have been none of the necessary supports granted to me as I have struggled to go back to work as a graphic designer and marketing specialist. For a short time, I went back to school at UMO, but this proved too much for me. Successfully launched my youngest child, and I spend time with my youngest grandchildren. I try to spend time with my friends and family, but my personality has changed, and I suffer from overstimulation and a lot of anxiety and fear, and living alone only makes it worse. I've lost friends and relationships with family members due to the changes I've had as a result of the brain injury. I require reasonable accommodations for everything that I do. After 11 years, there has been significant suffering due to the lack of support and services that I have requested, but not been granted, despite the fact that I am a member of the Maine Brain Injury Waiver Program. I have been bounced back and forth between the different sections of Maine Care, still with no in-home services that I desperately need. I'm in hopes that this bill, LD 559, will be the beginning of granting ABI survivors and their families the safety, understanding, dignity, freedom of all other citizens, and the desperately needed services that are essential. I encourage you all to vote for the passage of the bill. I just want to thank this committee for listening to the words of my constituent. It's not common that I do this, but I just know what a struggle it's been for her, and to try to navigate the system with me and even my legislative aide helping has been quite onerous. So I think a task force and further investigation into how we help these citizens among us would be very warranted. So I thank you for your time.
Thank you, Representative Krohowski. Questions for Representative Krohowski from, yes, Representative Craven.
Thank you, Madam Chair. I guess that when somebody's being sent home from rehab or the hospital, do they not judge whether a person needs assistance or whether they should be living alone or something like that? I guess I'm surprised to hear that.
And I can't speak to what happened many years ago, and I'm sorry that Ms. Lewis could not be here today. What I am aware of is the more current circumstance in which she is completely authorized to receive, I believe it's up to 16 hours a day of in-home assistance, and she has been unable to access any of this, and that has been the case for a long time. So she has gone, as far as I understand, and my legislative aide has understood, through the right steps to be approved for assistance of different varieties, and still unable to access that assistance. So I can't really speak to when she was first sent home, but I know that we're still not providing what we are supposed to through the Brain Injury Waiver Program, I believe it's called.
Thank you.
Any other questions? Seeing none, please extend the committee's thanks to Ms. Lewis for sharing her story. It's impactful and we're appreciative.
She thanks you for listening. I know she does.
Next, providing testimony is Ms. Courtney Michalik. Hopefully I didn't botch your name there.
Hi, thank you so much. Representative Meyer and distinguished members of the committee. My name is Courtney Michalik, and I'm an attorney at Disability Rights Maine representing clients with brain injury. I also serve on the Acquired Brain Injury Advisory Council and the Brain Injury Association of America Maine Chapter Advisory Board. Thousands of Mainers have dealt with brain injury. The effect of brain injury on a person and the changes in their everyday lives is profound. As it should, Maine law protects people with disabilities, except for those with brain injury. This legislation presents an important opportunity to right that wrong. As is reflected in my written testimony, efforts to secure rights and protections for people with brain injuries have been ongoing for over a decade. The law passed in 2011 fell short of including a specific statement of rights and instead directed the department to promulgate rules and articulate rights and protections, but that did not occur. This bill affords the legislature a chance to close the gap between people with brain injury and people with other kinds of disabilities. Instead of creating a new statutory scheme, LD 559 simply incorporates brain injury into existing statutes. The bill also establishes a work group to come up with rules that account for issues unique to brain injury. Neither of these provisions will cause hardship to the department. If anything, they will help promote efficiency in the way the department deals with concerns people with brain injuries already raise with respect to their services and their rights. The problems are already there, but the solution is not. Incorporating ABI into the existing statutory framework helps those concerns be addressed in a time and cost-effective manner, and the council has offered to facilitate that work group, so that should not create any additional burden. Some may argue that existing laws provide sufficient protection for people with disabilities. If the ADA or the MHRA were sufficient, our many laws pertaining to the rights of individuals with disabilities would not exist. The fact is that laws currently on the books do not provide the process or protections that people with brain injury need. Some may point to Maine Care rules as sufficient to provide protections that we're seeking for our clients. They are not. Maine Care is an insurance system with processes specific to it, but they do not protect the many Mainers with brain injury who are not on Maine Care. And this does not remedy the fact that there are statutes providing rights for people with other types of disability, but not brain injury. These laws contain rights that Maine Care doesn't address and can't enforce. There are many practical problems created by the lack of legal guidance in this area. For example, Adult Protective Services found that there was neglect when a brain injured man's guardian did not want him to have complete treatment for a broken arm. They wanted to remedy this, but they felt constrained because there was no explicit statement of rights for them to act upon.
30 seconds, Courtney.
So what this legislation comes down to is process and protection. Process for people to utilize when they encounter problems in their services, and legal protection they can rely on. We ask you to please vote ought to pass on this bill. We ask you to emphatically let Mainers with brain injury know that you see them, that they matter, and that they're worthy of protection under Maine law. Thank you so much for your time, and I'm happy to answer any questions to the best of my ability.
Thank you. Questions from the committee? Seeing none, we thank you for your testimony.
Yep.
Up next, Mr. Cowan.
Thank you. Good afternoon, Representative Meyer and distinguished members of the committee. It's good to see you all again, thanks to Zoom. My name is David Cowing and I live in Woolwich. I'm a founding member of Community Connect Maine. Our mission, as you know, is to connect families, caregivers, and communities to raise the standards of care for people with developmental disabilities and related conditions throughout Maine. I'd like to briefly share my thoughts on LD 559. As the legislative session goes on, this committee continues to listen to an overwhelming amount of information from many different groups. Once again, I'd like to express my appreciation for the hours and days you've spent listening to the many compelling and sometimes competing needs faced by so many of our fellow Maine citizens. In the past, I've spoken to you on behalf of families and individuals challenged by intellectual disabilities and autism. So why speak on behalf of individuals who have acquired brain injury today? Well, when I consider all the people who seek recognition from this committee, I think about how the needs of different individuals with disabilities overlap. My son's physical challenges are similar to many of Maine's elderly. His cognitive abilities with those dealing with brain injury or Alzheimer's. The impact of his mental health challenges could be compared with the obstacles individuals dealing with mental illness face, leaving them isolated and often incarcerated. The need for supportive social contacts and employment aren't really any different from the needs of any one of us. They're shared by all of us, disabled or not. As I've discussed with you in the past, someone who has a significant cognitive impairment, my son who has a genetic syndrome, a vet returning home from war with a head injury, or a grandparent with Alzheimer's, they all deserve and should be able to receive whatever supports they need that allow them to have a quality life in their home community. Over the years, I've listened to the stories of many individuals and families facing disability, whether it is one acquired prenatally, in infancy, by accident as a child or adult, or for whatever reason at whatever time in their lives. Providing the services necessary for someone to live a quality life impacts not only on the individual who has the disability, but their family's lives, the life of their community, and ultimately the quality of life in Maine and throughout our nation that I believe we all have aspirations to achieve. Compromising someone's rights as a citizen or their life prospects due to a disability diminishes all of us individually and collectively.
30
So
seconds.
thank you. Having the Commissioner of Health and Human Services convene a task force to develop and recommend rules and procedures regarding the rights and basic protections of persons with acquired brain injuries is a step in the right direction. And my hope is that this committee will support LD 559. Thank you once again for your time today, and please extend my birthday greetings to Senator Claxton.
We will do that. Thank you for being here today. Questions for Mr. Cowing? Seeing none. Up next, Mariana Edmonds. Welcome. You're on mute, Mariana.
So sorry. Good morning, Representative Meyer, and to all of you on the HHS committee. I come to you as a parent of an acquired BI survivor and very much in favor of the 559 Act. 15 years ago, my daughter suffered a rare viral encephalitis that triggered an autoimmune process at 14 years old, leaving her blind and cognitively disabled and with huge memory loss. Its origin was never determined after an open craniotomy and 2 years of steroids and Cytoxan, a cancer suppressant, an immune suppressant. Today, at 28, she is a young adult who is stable but needs 24/7 and is being treated under the ORC waiver. But what is needed is reinforcement of what the waiver asks for. And what I feel is most lacking is qualified caregiving that understands the complexity of her case, access to adaptive technology, such as a smartwatch and Nest, to be able to see when she's having a seizure in the middle of the night, which happens. But also this technology, which offers her the stimulation that she needs to gain for more independence in her daily life. She desperately needs community activity, cognitive and physical rehab, and vocational opportunities. As her parent and guardian, I would like to have more access to be with her. I haven't been allowed in her building for a year, but I am her only family in the state. We moved here from Arizona so she could attend the Perkins School in Boston, where she attained a high school certificate. And then I work full-time in Maine, and that's why we could live here. Maine's brain injury program has been a savior for my daughter, but I wish to advocate for improvement in her care, welfare, and sure and enforce security. And I want to thank you for listening to my case. And I'll be glad to, there's a lot of questions, and she has a very complex situation, but I'd be glad to answer anything.
Absolutely. Thank you for being here today. Yes, Representative Lemelin.
Thank you. Is COVID the reason you can't visit your daughter?
Well, that was true, but she lives in Iris Park Apartments for the vision impaired. I could remove her, but it takes a lot to move her out and to bring her up to where I live. And it became very disorienting when you don't have sight. And her brain processes, it wasn't always a positive thing to do. So I understand that, but I really feel some of the services aren't supervised and enforced enough for her to have the stimulation and to have the security that I need and that she needs to continue to stay stable and survive. The seizure disorder is significant because she just had an implant to stop seizures with a magnet and an implant. And someone has to be there, and she is not, she has no physical presence from 11 p.m. to 7 a.m. And it's done by a remote through a camera, which doesn't work, hasn't worked ever, and a smartwatch, which also doesn't work. So it's worrisome.
So at this time, while she's in that facility, you are not able to visit her?
Right.
And that's because of COVID?
That's true. Well, that's the decision of the manager of the building. However, we're under the services of goodwill, and they comply. They would like to have me able to visit her.
Okay, just to let you know on a sidebar that I have a bill coming up that is hopefully going to change that so that you can visit her during COVID.
Yes, I'm not considered essential. I have received both vaccines and she has received both vaccines.
Thank you. Any additional questions?
Thank you.
Seeing none, thank you for being here today.
Thank you.
Up next, testifying in favor of the bill is Mr. Richard Brown. Welcome. You're on mute, Mr. Brown. Still muted.
How about now?
That's good.
Okay.
Welcome.
Yes, right. Thank you, Representative Meyer and distinguished members of the Health and Human Services Committee. I'd like to start by just conveying a deep appreciation and thank you for all the work that you have done to support the needs of people here in the great state of Maine. In over 40 years of testifying, I don't think I've ever appeared before this august body without feeling that I was always listened to, not even once. So thank you for that. My name is Richard Brown, and I come before you today to share my knowledge from several life experiences related to brain injuries, recovery, and the system in Maine. I was the CEO of the Charlotte White Center for 38 years, where we operated residential and case management programs for people with brain injuries. I served as a board member and co-chair of the State-Acquired Brain Injury Advisory Council. I currently serve as a board member of the Brain Injury Association of America's Maine chapter. I'm the father of two fine sons who in separate incidents suffered traumatic brain injuries. Thanks to their strength and personal courage and care of family support as a good medical therapy, they went on to achieve complete recoveries. The human brain is such a complex, delicate, fragile, and yet tough and resilient part of our whole being that it is rare to find two brain injuries exactly alike. Yet the cascade of emotions around the event itself tends to follow a predictable repertoire of shock, grief, loss, fear, anxiety, confusion, supplemented with a desire to find consolation and hope. As recovery continues, people move from stages of rehabilitation to the reentry process and return to community life. Some of the members of the community of people with brain injuries have described it not as a process of recovery, but as a process of discovery, discovering the new person you have become post the traumatic or acquired brain injury. For many survivors, their lives will have undergone dramatic change, and that path back to discovery of your new self is fraught with peril at what is to come and filled with joy at what remains or is regained. In order to accomplish many of their goals, people with brain injuries need sureties along the way, touchstones that will not be swept away from underneath them as they begin their new journey. It is for this purpose that we come before you here today, to seek to enshrine the rights of people with brain injuries, to share in the protections that other people have also fought long and hard to win. People with intellectual and developmental disabilities, people with behavioral health challenges, who through the years of struggle, advocacy, and refusal to give up have prevailed in achieving a set of civil rights that was sometimes set aside, sometimes ignored as they searched for equality that was rightfully theirs despite the challenges that they bore up under. The You might ask why. Why do people with brain injuries require their own set of rights? Well, it is because until now, there has been no organized system of reviewing and resolving concerns, issues, questions, or complaints about treatment, supportive care, community integration, housing, and employment under a unified banner of rights of recipients of people with brain injuries. This bill does not intend to compose an entire new set of rules and regulations, but in fact to capitalize on the rules that are already written and add the unique needs of people with brain injuries into that mix. As a practitioner, provider, and father, I would urge you to develop solutions that incorporate the goals of this bill to create reliable civil and legal remedies and resources for any and all Mainers and their families who may be faced with surviving and overcoming the tragic circumstances of a traumatic brain injury or an acquired brain injury. Thank you.
Thank you, Mr. Brown. Representative Madigan has a question.
Yes, Representative. Hi.
Thank you for being here today, Mr. Brown. So what you're suggesting, what this bill's suggesting is similar to if an adult goes in to get, well, if anyone goes in to get behavioral health services, they are presented with the rights of recipients that explains them in detail and also gives them numbers to call if they feel those rights have been violated. That's what this would do for folks with brain injury.
Yes, it would open up that pathway of rights very similar to those of people with intellectual and developmental disabilities and behavioral health needs. In fact, if you think about how the language is written, really, we were only adding the line in or acquired brain injuries to already existing statutes. So I think that's a very, I mean, I've been in this process now for over a decade since we first began talking about a Bill of Rights, and we've gone from a manual that was like 198 pages down to one that was like just a front and back of one page. And I think what we've finally come to here and struck on is just a great compromise of how to do this without having to build a whole new system, but just, to be admitted into the systems that already exist and are very effective. Thank you for that question.
Thank you.
Seeing no other questions, thank you for being here today.
Okay, I guess I didn't need the breath mints. All right, thank you.
The upside of the virtual environment.
Right.
Up next
hey,
is
you're all
Mr.
doing great work. Thank you so much. Yeah.
Thank you. Mr. Wade, welcome.
Yes, thank you. Representative Meyer and members of the committee. My name is Steve Wade. I'm for the Brain Injury Association in Maine, and we're a relatively small charitable organization representing about 3,000 parents, families, and survivors of brain injury. And on behalf of the association, we certainly strongly support the bill and on 559. And it's interesting looking at brain injury as a disability versus other disabilities. The brain injury community is somewhat late in coming, because recently, as 30 years ago, maybe even 25 years ago, most people do not survive severe brain injury. There's been tremendous advances in trauma care, emergency response, 911, all these is in the war on terror. So, a lot more folks are surviving, but because we, this community sort of came to be after some of the other rights were already established for other disabilities. So I think that's one of the reasons perhaps that we're trying to catch up. And it seems like the bill takes a really efficient approach by just adding brain injury to the other disabilities that are also currently protected. So again, the association is strongly of support. I know the other interesting thing with brain injury, unlike, let's say, IDD or perhaps even behavioral health issues, is most folks living with brain injury are not covered under Maine care. So there's a whole classification of rules that would not apply. The last time I looked at the hospital discharge data, there were about 3,000 just traumatic brain injuries alone each year in Maine. If you include stroke, brain tumor, noxic, it's a pretty large number. Yet, to give you an idea, there's only about 200 people on the brain injury waiver compared to 7,000 on the IDD waiver. So it's a community, again, that's generally underserved under Maine care. And so again, I think that just helps to create a, just demonstrating the need for including brain injury within the existing rights. It's really simple equity, I guess, would be the best way to describe it. The other issue I think Dick Brown mentioned too is people with brain injury cross all the different silos. you've certainly heard of co-occurring ID and mental health issues or substance use. Well, the same thing with the brain injury community. People with brain injury have substance use disorder issues, they're very at risk. Same with behavioral health issues. So it's really, without a really firm set of rules, it's tough as people cross from system to system, within the overall system of support for people with disabilities. And I guess the final thing I'd mention is, we're hearing a lot more about COVID and COVID-related brain injury, the COVID long haulers you've probably heard of. And I think we're hearing about the cardiopulmonary issues, the long-term anoxic issues. I think we're just going to start seeing more and more folks who are ending up with acquired brain disorders as a result of some of the long-term issues around COVID. So it's a community that's unfortunately is growing, and there, if you also include all the folks who have an opioid overdose who survive with anoxic or hypoxic brain injury, again, this is really the edge in terms of disability, where I think much of the disability is now occurring in the state of Maine. So I'm pleased to answer any questions, and thank you very, very much for your support and taking the time to hear this today. So thanks again.
Representative Craven has a question.
Thank you, Madam Chair. Thank you very much. Actually, you talked about something that I hadn't thought about before, but that's the difference between people who qualify for main care and people who do not and has traumatic brain injury. So if somebody, how does somebody qualify for the waiver services? That's number one. If they don't qualify for main care, and do they have to pay? Out of pocket or their own private insurance for that? And for people who are not in the waiver program, do they have sufficient supports in the community, coming into their home or otherwise to be able to manage in that way? Or so.
Yes, all really good questions and very relevant. I think in terms of the brain injury waiver, it's a high level of disability that require to qualify for that. And there's also a pretty substantial waiting list right now. So I think there certainly would be opportunity to grow that waiver. But again, it's unlike some of the, which look at all levels of care. The brain waiver is focused on a very narrow, very high level of skilled care. So that's, I think, one of the reasons why it's, in comparing it to other waivers, why the numbers are the way they are. For folks that don't qualify for main care, which is by far the majority of folks with brain injury, and I think one of the things that's been helpful is when this committee approved the LD 297 services a couple of years ago. That whole focus of that was trying to help families navigate the system of care post-hospitalization. Because a lot of times if we can set up good, strong community-based services, we prevent folks from having to go on the waiver in the first place and that need the long-term or services or the facility services within a group home setting. So that's been a really big plus. But again, what we're finding is people typically have insurance coverage at the acute stage, but once they leave the hospital or rehab and return home, you're now looking at lifelong disability. So how do you sort of put your life together under those circumstances? And it can be a real challenge. Again, the existing services within ODES are very good. They serve only a small part of the population. So there are a lot of other people who don't currently have those services. And to the extent that we can help people, again, connect with services in their own community, we really are, in a way, delaying or preventing them from having to go on the ODES services. So I think that's probably the best place we can put our efforts, is really, again, helping those families navigate the system of care, which is, again, very fragmented. So I hope that, I know there were several parts. I may have forgotten one of the parts that are Representative Craven. So
thank you.
Thank you. Representative Madigan, your hand is up. Do you have a question for Mr. Wade? Thank you. Seeing no other questions, thank you for being here today.
Thank you very much. Thank you.
Our final testifying neither for nor against is Leland Glynn.
There we
Thank
go.
you. Thank you for the opportunity to speak with you today. I am a brain injury survivor. 3.5 years ago, I had a hemorrhage that leaked a couple of teaspoons of raw blood into my brain. And those 2 teaspoons of raw blood changed my life dramatically. I spent a week down in Portland in the ICU, and then the better part of a month in Augusta with the acute rehab. I came today not to speak either way on this LD 559, but to urge you to move forward with it, to level the playing field so that the people with acquired brain injuries simply have the same benefits that other intellectual disabilities have been granted and provided. I tell people that my brain injury obviously made me much better looking than I was previously. I know this for a fact because when I was in the hospital, I asked not to have visitors other than my spouse and daughters, because I was quite embarrassed by the condition that I found myself in. When I finally was released to go home, my friends came to see me and they all said the same thing. Gee, you look good. They never told me that before. So I know that it's a result of my brain injury. I would urge you to do the compassionate thing and to mark this as ought to pass. It seems like a simple little fix to what my knowledge as a layman is of it. All they're adding is the term brain injuries to other protections and rights that are already there. And I would hope that you'd see your way clear. Thank you so much for the opportunity.
Thank you so much for being here today. Questions for Mr. Glenn? None. We are deeply grateful for your sharing your story today. Thank you so
for the
much.
opportunity. Bye-bye.
I believe that concludes our testimony on LD 559. Questions for our analysts or requests for additional information from the committee for our work session? Yes, Representative Craven.
Thank you, Madam Chair. Yeah, so I would really like to, for people who have private coverage and need to be served in the waiver program, I just want to know how that's funded. Do you know if they don't qualify for main care or like that, will their insurance actually pay for them to have services in the facilities? Thanks.
Thank you. Anyone else? Seeing no further hands up, I will close the public hearing on LD 559 and open the public hearing on LD 590, which is sponsored by our committee's own Representative Michael Lemelin. Representative Lemelin, the floor is yours.
Thank you. Thank you, Representative Meyer and fellow members of the Health and Human Services Committee. I would like to present my bill LD 590, which states this bill requires the main care program to reimburse for ostomy equipment and supplies without prior authorization or limitation when recommended or prescribed by a physician. The reimbursement rate must be no less than the cost of the equipment. The Department of Health and Human Services is required to adopt implementing rules no later than January 1st, 2022. The purpose for which I presented this bill is due to the fact that at this time, there are ostomy supplies that are not reimbursed reasonably or even supplied by main care. These include items which work together for the proper function of a system utilized by the person who has an ostomy. These supplies are desperately needed for ostomy use and care. However, since MaineCare reimburses the pharmacy equal or less than the pharmacy's actual cost of the equipment, the result is the pharmacy refuses to provide the necessary equipment unless the person pays cash. The individual would then have to purchase the item at retail, which is twice the cost. Ostomy equipment is not optional. These supplies are medically necessary and their costs are restrictive or prohibited to those unable to afford them. In the past, MaineCare has paid for this equipment, so there's no real additional funding. So I ask for your support on LD 590. I have several constituents and someone close to our family, and also my son, who uses ostomy equipment. So I'm very familiar with this. It is definitely not optional to the user and has to be changed frequently, every 2 to 4 days. I've seen nurses who have made mistakes when changing this equipment because it's just not as easy as it looks. This equipment, of course, is mandatory. And what happens is now some of this equipment is either not being provided by MaineCare, or what happens is MaineCare is paying much less or even equal to sometimes the actual cost of the equipment. So now the person has to pay cash because like Kennebec Pharmacy here won't produce certain products. And the cash price, you have to remember, is twice what MaineCare would pay for it. So if the item costs $34, it would cost me or someone else $68 for that same equipment. And people on MaineCare, I know, just can't afford this. So this is why I brought it before you, and I thank you for your consideration.
Thank you, Representative. Questions for Representative Lemelin? Seeing none. Up next in the queue is Lisa Harvey McPherson.
Hello, Representative Meyer. And I do know that Senator Claxton isn't with you because I was just watching him in another committee. And committee members, my name is Lisa Harvey McPherson, and I'm speaking in support of this bill on behalf of Northern Light Health and our member organizations. To prepare my testimony for this bill, I reached out to our home care team. I thought the experience of nurses working with patients with ostomies at home would be a real-time reflection of the day-to-day lives of these individuals when their supplies are right or when they are not. So I framed my testimony around the stories, 2 stories that I received from nurses. And the first story, the nurses shared with me that it's nothing but a challenge to get MaineCare patients their needed supplies. Once you find a pouch that works, MaineCare will not cover that pouch, and companies must then provide products that are subpar for the patient. The product's not what is recommended, and it's not effective. The patients have trouble with adherence to their skin, it leaks, and they have to have the nurses come back repeatedly to figure out what's wrong. Not being able to get what you need for a patient with an ostomy is a nightmare for the patient, and it's also a nightmare for the nurse because we both fail. And the second story, for brevity, certainly is very similar. So as I heard from nurses, and I was thinking about this in the context of bringing value to the patient, you know, we're failing the patient when the product isn't right. We're really failing MaineCare because we're costing the program more to send nurses out into the home repeatedly to try and work with equipment that isn't the right fit for the patient. And we're failing our professionals who are dedicated to working with our patients in the home and improving their health and well-being. And sometimes the supplies are the driving factor that they simply can't overcome. So with that, I want to share with you our strong support and welcome any questions that you have.
Thank you, Ms. Harvey McPherson. Any questions for Lisa? Just a quick one from me. The the bill reads, when recommended, without prior authorization or limitation, when recommended or prescribed by a physician. I'm assuming that any professional with prescribing abilities would be fall into that category?
Yes, and I believe you have testimony from the nurse practitioners that highlight that fact.
Okay, thank you. Any other questions? Seeing none, thank you very much, Lisa.
Thank you.
Up next, Tricia Foley, please.
Hi, everybody. My name's Tricia Foley. Can you hear me okay?
We can.
Wonderful. I am a wound ostomy continence nurse here at Maine Medical Center, and I've been a nurse for 20 years, a wound ostomy continence nurse for about 14 years. So I see adult, pediatric patients. I see teens with ostomies. I have worked here at Maine Medical Center for many years, and I would say over the past 5 to 6 years, the majority of patients that I have seen where this becomes an issue is in the pediatric and neonatal population. I can give you one example, which had happened last fall. It was September of last year, but my example happens multiple times a year whenever I have these pediatric patients. And I say that because many of the pediatric patients, I would probably ballpark about 85% of these patients are on main care. So this one particular patient, she had spina bifida. She has a permanent ileostomy. So that's where they had to bring the ileum out through the skin, which drains very caustic drainage, and you have to keep the skin around that stoma protected. Her stoma was less than ideal because she had had previous abdominal surgery to create what's called an appendicovesicostomy, where the child actually has to catheterize through the belly button in order to drain her urine. So she had a lot of scar tissue within her abdomen, which created for a less than perfect ileostomy. So her ileostomy was fairly flush with her abdomen. And when that type of thing happens, we need, as ostomy specialists, we fit them into a perfect product. And in this case, this patient needed a pre-cut convex product. Which main care would only cover a portion of that cost. And when I explained, I was talking with the providers. I'm not a provider, I'm a nurse. And when I was talking to the mother, and we told her, the durable medical equipment provider will pay X amount for this product, but the copay is going to have to be this. She said, I can't afford that. I don't know what I'm going to do. I can't afford this. So those are situations that happen. We had to place this patient in a less than ideal product. And what had happened is the patient had leaking. The product had to be changed more frequently. There was skin irritation around there. And so I have many examples just like this one where we have to put them in an alternative product. So as an ostomy nurse, it's very frustrating because there are specialized products that we fit to the patient and to the stoma, which really with main care constraints, we just can't provide that for the patient. So that's kind of one side of the story. Now, there's also, when we consider the term ostomy, it was also brought to my attention that patients that have cecostomies, and I don't know if anybody's familiar with that term, but it is when children have chronic constipation where they failed all medical treatment. They actually have to have a surgically created catheter that's placed into their colon. And that's where we irrigate that. And then that allows for them to have a normal bowel movement. Cecostomy supplies, the little tube that goes into the skin to allow us to irrigate. Those can be about $200. And those are not covered by main care. So families actually have to sign something ahead of time saying that, yes, they can indeed or will find a way to pay $200 for the cecostomy tube so that they can have the this intervention that they need to relieve their constipation. And that tube also has to be replaced about every 3 months. So it's about $800 a year for that family, which for a lot of our main care families, that's a significant amount of money for them. So there's the ostomy supplies for those surgically created stomas. And then there's the other side of things, which is a cecostomy, which is a little bit different, but it still falls under the category of an ostomy and supplies that are required for these patients. Any questions about that?
Thank you, Ms. Foley. Representative Lemelin has a question. Go right ahead.
Yes, thank you. Thank you for that great testimony. You brought back some huge memories of the past. We had similar issues, and if it wasn't for nurses like yourself who came to the forefront and helped us through these very difficult times, we wouldn't have made it. So I thank you. But number two, is the cecostomy similar to a Malone stoma?
A Malone stoma. I've never heard that term before, if I'm being 100% honest with you. Malone stoma.
Yeah, that's okay. It's another way where a person has to void. So I was just wondering if it was.
There's a Mitrofanoff type of a procedure, but it Malone, I think might be a different term, but it's essentially, yes, it's kind of that antegrade colonic enema. Sometimes it's referred to as like an ACE type procedure, ascending colonic enema, similar, but I've never heard the term Malone, but it sounds like it is right along the same lines.
Okay, thank you again for your testimony.
Sure. Additional questions for Ms. Foley? Seeing none, thank you for being here today. I believe that concludes the testimony on this bill. Do we have requests for additional information for our analysts for the work session? Yes, Senator Moore.
Thank you, Madam Chair. I was just looking over the Director of Main Care Services testimony, and I guess I would be interested in knowing what is she is saying that they do not require a prior authorization for ostomy supplies, but there's a 90-day limit. So I guess I would be interested in what is the cost, for example, of the 90-day supply. And then she was saying the department currently reimburses for the products at 85% of the Medicare rate. So I would like to know what that actual rate is, just for additional information. Thank you.
Seeing no other requests for information, I will close the hearing on LD 590 and open the hearing on LD 624, an act to amend the laws governing tobacco specialty stores, and welcome Representative Harrington to provide his testimony. Welcome.
Good afternoon, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. I'm Representative Matt Harrington. I represent House District 19 down here in York County in the city of Sanford. I'm here today to present LD 624. This bill is very straightforward. I'm looking to remove the prohibition on drinking water in the only retail establishment where it's still prohibited: cigar specialty shops. Some testimony has mentioned food, which is not my intention, only non-alcoholic drinks, like every other retail establishment in Maine. New Hampshire and Massachusetts both allow for full liquor licenses in their cigar lounges, and that is not what I'm asking for, simply water. We are behind our neighboring states, as we are on many levels. This is not a smoking bill. We are already allowed to have cigar lounges. Cigar smoking is a very small niche community. Passing this bill will not expand smoking, as several groups have alleged. To sample a cigar, you smoke the entire cigar. That can take an hour. Cigars are complex and you sample the whole cigar before spending $200 to $400 on a box of 24 cigars. You cannot simply light a cigar for 1 or 2 puffs as suggested. I know one small business in York County that was closed due to fines stemming from patrons simply drinking water. Those who didn't want to break the law simply got their water from going to the bathroom multiple times and drinking water from the faucet in the bathroom. How is that sanitary? I would hope this committee would critically think and support this legislation. 2 years ago, I put this bill in asking for what our neighboring state allows in New Hampshire, which is a full liquor license. Simply not asking for that at all. Just remove the barrier to drinking water in the only retail establishment still left in Maine where you cannot have a glass of water while you shop. Thank you. I'd be happy to answer any questions.
Thank you, Representative. Questions for Representative Harrington? Yes, Senator Moore.
Yes, thank you. And thanks, Representative Harrington. In looking at the summary of the bill itself, it really is not specifying just water. And then it also goes on to talk about providing notice to all the applicants for employment that they would be working at tobacco. Are you proposing an amendment to your bill? Is that what I'm hearing?
So what I had asked from the revisor's office was non-alcoholic drinks. I'm trying to make just a clear point that it's non-alcoholic drinks. So there's no way to really specify that. It would be if someone brought coffee or soda in or whatever, that would be the intention of the bill, just non-alcoholic drinks. But the second part of that question is obviously to work in a shop like that, there are inherent risks, and I would obviously support requiring that you notify employees, albeit that it's quite obvious that there are hazards working in that environment.
Thank you.
Representative Zager, did you have a question?
Thank you, Madam Chair. I withdraw because Senator Moore asked. Thank you.
Okay. So one from me. So is it simply water or is it non-alcoholic drinks? Because that would include soda and apple juice and
Non-alcoholic drinks.
Okay, so it's not just simply water.
I would actually be willing to just refer to just water if we could get this bill passed. But as presented, it was non-alcoholic drinks.
Any other questions from the committee? No. Thank you very much.
Thank you
for being here today. Up next in the queue is Allison Dragg. Welcome.
Hi, thank you, Representative Myers, Senator Claxton, members of the committee. I'm Allison Dragg from the American Heart Association, and we are testifying in opposition to 624. We have concerns over expanding places where smoking is allowed and exposing workers to secondhand smoke. When the law was passed in 2006, the Maine smoke-free law, there was a loophole uncovered. So in 2007, the AHA, along with other partners, worked to create a public health law that seek to change that. At the time, it was really concerned that cigar bars and hookah establishments, and these were bars that were using licenses like tobacco specialty shops, and to work around the smoke-free laws. We saw this loophole in Maine, and we sought to close it. This committee actually voted unanimously to support that effort in 2007. The only reason that tobacco specialty shops themselves were exempt from Maine's smoke-free workplace law was because they were made the case that customers needed to sample expensive cigars before making their purchase. And for several years, similar measures came before the legislature and have been defeated. We believe we don't need to be creating more appealing environments for people to be exposed to secondhand smoke or being addicted to smokers. We believe our smoke-free workplaces and public place laws protect Maine residents from secondhand smoke, and we ask you to ought not to pass on LD 624.
Thank you. Questions for Allison Dragg? Seeing none. Thank you for being here today. Next is Sarah Calder.
Representative Meyer, Senator Claxton, members of the committee. My name is Sarah Calder. I'm the Director of Government Affairs at Maine Health, and I'm here to testify in opposition to LD 624. The bill before you today represents a concept that has been before the legislature multiple times in various iterations, as you heard, since loopholes in Maine smoking laws were closed, and that concept has continuously met no success. Previous bills have represented regressive efforts to roll back Maine's strong support of tobacco-free environments, taking environments exclusive to the sale of tobacco and expanding the scope of service to include the sale and use of alcohol. The legislation before you today continues this regression. And because it runs contrary to the overwhelming public opinion here in Maine that's supportive of tobacco-free environments, it's important to note that the identical language that is before you today was defeated by the 129th legislature. And I would also note that smoking in confined spaces can also compromise the use of face masks as someone who would need to take the mask off to smoke, which could further contribute to the spread of COVID-19 when a smoker exhales, touches their face, etc. So because of that, I would urge this committee to vote ought not to pass on this bill. Thank you.
Thank you, Ms. Calder. Questions for Ms. Calder? Seeing none, thank you for being here today.
Thank you.
I see Hillary Schneider is in the queue. Ms. Schneider.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Hillary Schneider, and I'm the Maine Government Relations Director for the American Cancer Society Cancer Action Network. We'd like to thank you for the opportunity to submit this testimony in opposition to LD 624. I'm not going to repeat some of the stuff that my colleagues for our partner organizations have stated, but as stated, if you look in the legislative history of the law that is looking to be amended, the prohibition on consumption of food and drink was put into law because the AG's office and the Maine CDC were seeing applications for in 2007 for entities that wanted to start up as smoking lounges. And I would say even with the piece around non-alcoholic beverages, you're still looking, I did hear the sponsor of the bill talk about tobacco lounges. And while it was stated that this isn't about smoking, what we do have concerns over is if, again, as you heard, the intent of the tobacco specialty store exemption was really around tasting premium cigars. So you heard the sponsor say that it's about people sitting around and smoking a cigar. We don't want to promote places where people are sitting around for hours together, convening and smoking. That is a smoking lounge. That smoking lounges are prohibited except for one grandfathered entity in Maine. And we actually believe that this would create not a level playing field where you have restaurants who can and coffee shops that cannot allow smoking, but now you're creating this separate set of entities that can essentially be a coffee shop that allows smoking, which is creating a culture that is more conducive to smoking in the state. I would also note that if you look at these entities, children under 18 are allowed in tobacco specialty shops when they're accompanied by an adult. So you also can run the risk of having kids come in, be with an adult who wants to smoke a cigar for an hour and now drink a beverage and hang out and bring their children in with them. So we do
30
believe
seconds, Hillary.
that you would be creating more smoking, and you would be creating a culture that is more conducive to an accepting of tobacco use. And for these reasons, we encourage you to vote not to pass an LD 624. I'd also encourage you to ask the AG's office how many violations have been in Maine for drinking water. It is my understanding that the violations for that York County establishment went well beyond drinking water.
Thank you, Ms. Schneider. Questions for Hillary Schneider? Seeing none. Thanks for being here today. Up next is Molly Bogart.
Good afternoon. I'm Molly Bogart, Director of Government Relations for the Department of Health and Human Services. Just testifying briefly to concur with the folks who've spoken in opposition to this bill and bring your attention to a letter from Deputy Director Nancy Beardsley of Maine CDC that you've received through the testimony portal. I think it's clear to us that the language is unclear around what kind of beverages would be allowed, and from an enforcement perspective, the health inspection program would certainly need some more clarity around what we would be expected to respond to if this allowance was extended to tobacco specialty stores. Then they would likely need to be licensed with the health inspection program if they were preparing and serving any kind of drink or food. And so at the very least, clarity would be appreciated. But from the public health perspective at Maine CDC, we also are concerned about expanding opportunities for individuals to be subject to secondhand smoke. And for that reason, we would not like to expand any of the allowances at tobacco specialty stores. So we can answer any questions or participate in the work session if helpful.
Thank you, Molly. Questions for Molly from the committee? Seeing none, appreciate your testimony here today. I believe that concludes the testimony on this bill. Do we have any requests for additional information from our analyst for the work session? Yes, Representative Zager.
Thank you, Madam Chair. I actually am interested in if the AG's office could provide more information about other violations. I think context matters, and it's no secret that I'm strongly opposed to anything that diminishes health. And so I'm very against smoking as a professional and also as a representative. However, I recognize people's right to lawfully exercise their own decisions about such matters. So I am interested in what has been talked about specifying exactly what is this just water, or is this a food and beverage establishment? There's a whole spectrum there. And so I think for the work session, I'd be interested in stakeholders weighing in or providing input about making a very narrow cutout so that people who are lawfully patronizing an establishment can have access to water. I think that doesn't necessarily promote smoking, although it does make it more enjoyable for a patron of an establishment that does promote smoking. So I just think for the purpose of discussion, I'd be interested in stakeholders' input on that narrow proposal or amendment.
Thank you, Representative Zager. Yes, Representative Javner.
Thank you very much, Madam Chair. Yeah, I appreciate Representative Zager's request for information. That is part of what I was going to ask as well. I would really like those numbers from the AG's office. Also, I'm looking for even the number of cigar specialty shops that this would include. And then also what the licensing differences would be specifically for these specialty shops if they are to offer non-alcoholic beverages or even just water. Since no food is going to be included in this, I would really like that information for the work session so we see what those licensing differences would be. Thank you.
Okay, thank you. I would ask that the chat function not be used for any substantive conversation about this bill or any policy before us. Senator Moore, did you have a question or a request for more info?
I did, but Representative Javner asked that for me.
There you go. Anyone else? Anything further? Seeing none, I will close the public hearing on LD 624 and open the public hearing on LD 699. An act to create a kinship care navigator program within the Department of Health and Human Services, presented to us today by our own Representative Holly Stover. Representative Stover.
Thank you, Madam Chair. Good afternoon, Senator Claxton, Representative Meyer, and my esteemed colleagues of the Joint Standing Committee on Health and Human Services. My name is Holly Stover, and I represent the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and South Bristol in the House of Representatives. Thank you for the opportunity to appear before you today to present LD 699, an act to create a kinship care navigator program within the Department of Health and Human Services. This bill requires that the Commissioner of DHHS commit to one position to oversee all matters related to the placement of a child in kinship care. Kinship care refers to the care of children by relatives, or in some situations, close family friends, referred to as fictive or fickin. There are many reasons why a child might need kinship care, but often it is when a tragedy has occurred, such as an untimely death of a parent, an inability of a parent to care for the child because of mental illness or substance use disorder, or other situations where there's jeopardy for that child. There are cross-cutting systems that are involved in kinship care, including child welfare, criminal justice, and the judiciary. We know that there are thousands of grandparents and kinship families raising children in Maine. This trend has been exacerbated by the pandemic. On a personal level, my brother came to live with my family when his mother, my father's sister, or my aunt was murdered in a domestic violence homicide-suicide. My younger brother was not yet 4 years old when this occurred, and he was a witness to the crime. I often think, what would have happened to him if he had not had the support and love of his family over the many years of trauma supports and intensive therapy? In my opinion, kinship care saved his life. This kinship navigator would be embedded within the department and would be the resource inside DHHS that would provide resources, supports, and information about benefits, legal systems, and other services needed to support a child in that placement. The provision of information and referral would be helpful in connecting to various therapeutic services and community engagement, including recreation. The service has been provided through contracted services with an agency provider. This would alleviate the service, this would elevate the service to be within the department with access to records and information like any other OCFS employee. There have been instances where there has been inherent value of having a caseworker position internal to the department rather than contracted from an outside agency. The goal of this bill is to provide the highest quality kinship care to Maine's children and families. These are often situations that require a crisis response, and having a consistent position within the department would ensure continuity in the transition to kinship care. Thank you for listening, and I am willing to answer any questions you may have.
Thank you, Representative Stover. Questions for Representative Stover? Yes, Senator Baldacci.
First, I want to thank Representative Stover for that bill. Having worked in the family law area for a long time, I've dealt with tens of dozens, if not hundreds, of grandparents or extended family members who want to take care of a child in a very difficult situation. Does the department already have staff for kinship care? And how is this going to improve what they're doing in terms of placing children with extended family members?
I'd for that question to Molly Bogart.
Okay. If she's here, but if she's not,
I can say that currently it's my understanding it's a contracted service. Okay. So this would just create, and it is not a question of quality. And I wanted to say that it is not a question of quality of that service. It's just about having the position internal to the department and changes the access that that worker has to certain documents and information.
You're on.
Thank you. I think when we have the work session, I'd really like a briefing on where the department is on kinship care in general. it goes through stages. But one of the reasons why there were fewer children in custody from 2002 to 2010 was because there was a big expansion of kinship care. And then it goes through stages. It is the best possible alternative for so many kids to be placed with extended family members versus foster homes that I think we should spend some time, because I'm not always certain the department or the individual caseworkers are promoting it as much as they can, but I know because they have a statutory mandate to promote it. But if we could get a little bit of briefing from the department on kinship care, like what their staffing is, what their procedures are, I definitely support doing something like this to promote the role of kinship care. I think it will be helpful overall to place more children with extended family members.
Thank you, Senator. Up next in the queue for testimony is Anthony Lombardi. Mr. Lombardi.
Representative Meyer, Senator Claxton, and honorable members of the Committee on Health and Human Services, good afternoon. My name is Anthony Lombardi, and I'm a legal fellow at GLBTQ Legal Advocates and Defenders, New England's leading legal advocacy organization for LGBTQ rights. And I'm also a lobbyist associate of Mary Bonato. I'm here today on Ms. Bonato's behalf to share the support of GLAD, the ACLU of Maine, and Equality Maine for LD 699. And we've also submitted longer written testimony with supporting research. This bill meets an urgent need for children who need care by providing resources and information to facilitate kinship providers, both relatives and people with a close relationship to the child, to step up temporarily or permanently when the child's parents are unable to do so. The current system is a Byzantine one to navigate, and this program would aim to get everyone on the same page, democratize access to newly organized information, and take an important step to improving the lives of a significant number of children. The system is important for all children, whether or not in DHHS custody. As to the department, this program would benefit children by clarifying how the department and caregivers can connect in circumstances ranging from providing families a temporary respite to placement of the child after removal. GLAD has a deep interest in ensuring that all children and families involved with the department and the foster care system receive timely and targeted care and assistance, both to promote children's welfare and to support families. However, for LGBTQ young people in particular, the recent data we have from the 2019 Maine Integrated Youth Health Survey demonstrate that LGBTQ young people experience less support from adults and increased violence and discrimination at home, at school, and in the community as compared to their non-LGBTQ peers, each of which is a warning sign about possible involvement with the child welfare system. National research shows that LGBTQ youth are disproportionately involved in the foster care and child welfare system across the country, and the proportion of LGBTQ youth in foster care and unstable housing is 2.3 to 2.7 times larger than that would be expected. And inevitably, many of these youth are also Black, Latinx, Indigenous, and other people of color. The Williams Institute, a think tank at UCLA School of Law, among others, has found that LGBTQ youth of color are overrepresented in both the child welfare and juvenile justice system. These youth stay longer in child welfare and in the juvenile justice system and are at an elevated risk of discrimination and violence once system involved compared to other groups of youth. Data also show that LGBTQ young people are at a heightened risk of harm when in foster care that might be alleviated in part by more accessible kinship care.
30 seconds, Anthony.
GLAD views this bill as a common sense and urgent imperative to provide resources and information to willing care providers and thus to protect our young people and promote their well-being. We also want to elevate our support for Professor Deidre Smith and encourage the community to consider her expertise on this matter and her testimony. Thank you for your consideration, and we urge you to unanimously vote out to pass. And I'm happy to answer any questions.
Thank you for your testimony. Questions for Mr. Lombardi? Seeing none. Thank you for being here today. Up next in the queue is Deirdre Smith. Welcome.
Thank you. Good afternoon, Senator Claxton, Representative Meyer, and other members of the Joint Standing Committee on Health and Human Services. My name is Deirdre Smith. I'm a resident of Pownell, Maine. I'm an attorney, and I'm also a member of the faculty at the University of Maine School of Law. I'm the managing director of the law school's legal aid clinic, where I supervise students who represent low-income individuals in Maine's state and probate courts. My testimony in support of LD 699 represents my personal views only and not those of the law school or the University of Maine system. My interest in kinship or relative caregivers really stems from my work in the clinic, supervising students, particularly in minor guardianship cases. And that led me to research the role and the needs of relative caregivers, particularly those who are caring for children outside of having a formal role in the child welfare system. So as Senator Baldacci referenced about kinship placement, there's formal kinship placement when a child has been removed from the home by the department. But then there's what's referred to as informal kinship care. This may still be as a result of an intervention by the department, but it's not a formal placement that's part of a child protective matter. I learned from my work with kinship caregivers in these contexts in particular that there is an urgent and immediate need to provide them with more support. And I'm particularly appreciative of the language in LD 699, which does not restrict the eligibility for services for relative caregivers to those having a formal role in the child welfare system. Research indicates that across the United States, for every child who's in the foster care system, there are 19 who are living with a relative caregiver, but outside of the formal child welfare system. My written testimony includes a lot of citations and research that I've done, so I'm just going to sketch out a few brief points here, and just want to say I'm obviously happy to answer any of your questions. Representative Stover did an excellent job sketching out the high incidence of relative caregivers that we have here in Maine and the really tragic circumstances or crises that can lead to a child coming into the care of a relative. In some instances, the child is coming into that relative's care at the suggestion or strong urging of the department, even if there isn't a formal child protection matter. That means that these relatives are often finding themselves very suddenly and very unexpectedly in the position of needing to enroll a child in new school, access healthcare, including behavioral health systems, obtain public benefits. They have little or no support for the role that's been thrust upon them. The department,
seconds, Deirdre.
The department may also urge these relative caregivers to seek formal legal custody through a minor guardianship action in Maine's probate courts. However, the state does not provide them with an attorney or detailed information about seeking guardianship. As a result, these relatives must figure out and access all of this information on their own. So kinship navigator programs have been around since 2005 across the country. There are about 70 programs. There are excellent models out there for Maine to adopt. And there is also the possibility of federal funding to enhance Maine services. And again, I've outlined all of that in my written testimony, and I'd be happy to answer any questions that committee members have. Thank you for the opportunity to testify before you today.
Thank you for being here. Questions for Ms. Smith? Seeing none.
Thank you.
Up next, providing testimony in opposition to the bill is OCFS Director Dr. Landry. Welcome, Dr. Landry.
Thank you, and good afternoon, Senator Claxton, and may I add my birthday wishes to you today. Representative Meyer, members of the committee, I am Todd Landry. I'm the Director of the Office of Child and Family Services within the Department of Health and Human Services. I want to thank Representative for bringing this bill forward and provide you with some information on why we're testifying in opposition today to LD 699. As you have heard, this bill would establish within the department a kinship care navigator position to provide resources and information to persons providing kinship care to children. OCFS believes this bill to be unnecessary as we currently fund kinship services through a contract with Adoptive and Foster Families of Maine, also known as AFFM. In federal fiscal year 20, OCFS was awarded a federal grant for a kinship navigator program. Funding runs from 10/1/19 to 9/30/21 with a total grant award of just over $225,000. AFFM is an organization with significant experience delivering services and supports to foster and adoptive families, and the Kinship Navigator program was awarded to them as a result of a competitive RFP. Prior to the award of the contract, AFFM had their own kinship program, but it was funded solely through donations. I provided you with a link to learn more about AFFM's kinship program. I will tell you through this program, AFFM has provided direct support to grandparents and other relatives who take primary responsibility for the care of children who are in need of a safe and stable environment. There is no requirement that the family have child welfare involvement or otherwise be connected to AFFM in order to receive services under this kinship program. AFFM has a staff of 4 kinship specialists who have identified resources specific to the unique needs of this population, and they provide referrals, community outreach, training, and a kinship resource guide developed by AFFM. In the last federal fiscal year, AFFM delivered kinship-specific training to 258 individuals. That number likely would have not been even higher, but they had to reformat their programming during COVID for an online delivery versus in person. AFFM, I should note, also provided various types of support to 340 informal, meaning not connected with child welfare, kinship families. OCFS does not believe that a single designated individual within the department could have the same impact on kinship-related issues as AFFM, which is a statewide organization widely known and respected. AFFM already has the framework and the support for the kinship program, which fits well into other programming also offered by their organization. I'd also like to point out that the Family First Prevention Services Act, which we've discussed before in this committee, allows for the use of 4E prevention funding for kinship navigator services. Unfortunately, at this time, no kinship navigator programs have been approved for use of this funding within the ACF clearinghouse that we've discussed before. We continue to track programs under consideration for approval, and if an evidence-based kinship program is approved, OCFS will consider implementing it in Maine. I thank you for the opportunity to testify before you today. Happy to answer any questions, and specifically, Senator Baldacci, I'd be happy to address your question as it relates to how this impacts the caseworker role for families, kinship families, and children involved with the child welfare system, if you want to ask that again.
Thank you.
Go right ahead, Senator Baldacci.
Oh, okay, sure. Thank you. Mr. Landry, in terms of, first of all, do you see a way that this proposed bill can actually assist the department and doing an even better job at providing help and support to extended family members? That's one question. The other question, I think, goes back to one of the ones I asked you originally, because I still need, I know you provided some statistics and maybe I overlooked it, was trying to see where the number of kinship placements have been over the last 10 or 15 years. I would like to get some more information on that, but having dealt with, I really respect Professor Deidre Smith's work, and having dealt with hundreds of these kind of families myself, I'm well aware that what she's saying is in fact true on the ground, that there needs to be more support for kinship placement in general. It helps all of us. So one, do you think this bill can serve some useful purpose to help us achieve that objective? And two, if you could give me statistics later on the last 10 or 15 years of kinship placements. And I appreciate your time. Thanks.
You bet. So let me try to answer a couple of those questions, then we can get you some additional information. I think it is important to note, to one of your earlier comments, that that the Kinship Navigator program offered through AFFM and that we contract with them to provide is for both involved, child welfare involved families and kinship families, as well as those not involved with the child welfare system. And so one of the big advantages of AFFM is they're able to provide that service for both sets of populations. And as you may expect, sometimes a kinship care family that's not involved with the state may be hesitant to reach out to the state. They are much more comfortable to reach out to a community-based organization in many of those situations. So to me, this bill doesn't necessarily help with that in any way. And in fact, I think it could, in fact, deter some families from reaching out to the department for that assistance. So I don't necessarily see that it is a significant help. If the belief is that there's greater need for kinship services, we can certainly talk to the committee about what the numbers look like, what the volume looks like. Well aware of Ms. Smith's research, and then the committee could decide whether or not they want to potentially fund additional services. My recommendation would be to add it to the federal dollars if you wanted to do that. You would, to me, we'd add it to the federal dollars to gain more leverage and increase the capacity that's already there. As I said in my testimony, AFFM already has 4 kinship navigator positions within their organization providing this support to these families. Not sure exactly what one position within the department would do to help that versus adding to their already existing base of services. The other thing I will point out is that this does not in any way change the role of the caseworker in working with kinship families if they are involved with the child welfare system. That work continues, and this is an additional support that's offered to those families as well. But the caseworker support work that happens in situations of child welfare involvement continues regardless. So it's additional casework services because of our court-ordered involvement in those cases versus replacing it. I wanted to be clear about that. I can tell you for the past 5 years, our number of placements with kinship or relative caregivers has been right around 42 to 45% on a very consistent basis. As of last month, 43% of the children that are in the care and custody of the department are placed with relatives. And that's been a very consistent number for the past 5 years. Be happy to go back and get you the data for the past 10 or more years.
Thank you, Dr. Landry. Senator Moore.
Thank you, Madam Chair. Thank you, Dr. Landry. I just had one quick question. The federal grant that we are under right now, is that a renewable grant? Would we be able to continue to do that?
It is currently a renewable grant. It's important to note that the grant was available to the state for a number of years. The previous administration, as I understand, chose not to apply for that grant. Beginning 2 years ago, we did apply for that grant here in the state of Maine, received the grant, and we intend on continuing to apply for that as long as it's available from the federal government. Now, I think one of the things the federal government is considering is that once there are more than one kinship navigator programs on the clearinghouse, I think there may be some consideration that they will want more states to utilize those models of service through the 4E program versus the Kinship Navigator Act program or funding program. So we'll see how long it continues, but there's no indication at this point that that funding source is going to go away. And as long as it's there, certainly it's my intention that OCFS would continue to apply for that grant. Different administrations in the future may have different perspectives, of course, on that.
Thank you.
Thank you. Representative Stover.
I just wanted to thank Dr. Landry for your comments today. And also I appreciate the work that is being done by the agency. The thought behind this bill was to enhance, to bring about more resources to the department, and certainly wasn't looking at addressing any quality issues with the existing service. It was just about enhancing the current efforts. Thank you.
Thank you, Representative. Seeing no further question. Go ahead, Doctor.
I'm very sorry to do this, and if you would prefer me not to, but one of my staff members was able to provide me with a chart on relative placements as a percentage of our total children in care, and to Senator Baldacci's question, if you'd like, and if I have the ability, I'm happy to share that screen with you as well as provide it to you in the future, but I defer to you as the chair.
Is that something that you could make available to us at the work session?
Certainly, we'd be happy to do that in advance of the work session. This chart goes back to 2008, so I think it may address the senator's question, and we'll provide that to you.
Thank you so much. And thank you for being here today. Up next in the queue is Jessica Gleason. Ms. Gleason,
Yes, can you hear me?
we can.
Okay, wonderful. Thank you, Representative Meyer and members of the Health and Human Services Committee. My name is Jessica Gleason, and I am here today to speak in opposition of LD 699 and to recommend an amendment of it proposing that the Kinship Care Navigator program not be housed within DHHS. In 2015, I learned firsthand of the trials and tribulations of kinship care as I became a kinship placement for my one-year-old niece. At the conclusion of 2 torturous years, I filed an ombudsman complaint and hired my own attorney. I won that ombudsman complaint and I lost $3,000 on the attorney. While I support a kinship navigator program, I speak today in opposition of LD 699. If we look deeper into LD 699, we learn that in 2017, a kinship advisory group was formed as a result of a conversation initiated by LD 270. The group included representatives from state legislature, state government, child protection attorneys, and other interested parties. They met 9 times in 2 years. Their final report was submitted to Senator Eric Brackey and members of the Joint Standing Committee of Health and Human Services in 2018. They concluded, and I quote, that the Kinship Navigator program should operate independent of DHHS, end quote. On another note, in a report produced by Generations United, in an effort to implement a Kinship Navigator program and meet regulations and follow evidence-based practice to ensure allocations of funds, it is the direction of Generations United that, and again, I quote, house the program in trusted community organizations, not the Child Welfare Agency. In general, with very few exceptions, these programs should not be housed in child welfare agencies because of fear and trust issues, end quote. Fear of DHHS, absolutely. I testify firsthand at the rightful fear and the lack of trust I developed with DHHS. They worked with blinders on and without consideration of the safety and the best interest of my niece, evident by the emergency room visit and the stitches that she needed following the first hour of the first unsupervised visit when she was found in a hotel room with her head cut open and her bio mom working in another room. The next day, my niece was returned to endure 30 more days of trauma. My fear and lack of trust with DHHS is undeniable. What we also cannot deny is the breadth and depth of many individuals have painstakingly spent evaluating the Kinship Navigator program and their conclusion that it should be held outside of DHHS. Housing a Kinship Navigator program inside DHHS is like housing it within a circus, a sit on the edge of your seat during a lion tamer act part of the circus. One cannot trust or feel safely guided if they are waiting for a lion to jump through the door. While I support and recognize the necessity of a Kinship Navigator program, I am appalled at the blatant neglect of LD 699's failure to recognize the efforts of past committees and the failure to respect those committees' recommendations of housing the program outside DHHS. In closing, I ask that the committee consider opposing this bill in its current form and reconsider an amendment with the Kinship Navigator program to be housed outside of DHHS. Thank you.
Thank you, Ms. Gleason. Questions for Ms. Gleason? Representative Stover, your hand is up. Did you have a question? No. Thank you. Seeing none, we thank you for being here today and for your testimony.
Thank you.
That concludes testimony on LD 699. Looking for requests for additional information from our analysts for the work session. I guess from me, I would be interested in the 2017 Kinship Navigator Program report that was referenced in the last testimony.
That's a good idea. Yeah. Good idea.
Representative Stover?
For the work session, I was going to suggest that we invite the folks from GLAD that presented earlier to hear more about their concerns as we work through the issues of the bill. They had some very specific issues. And it would be good to see if those are addressed through the existing agency contract.
Thank you. Senator Baldacci.
I just want to make sure, have we invited or at least given notice directly to, because I know there are some kinship care organizations in different parts of the state. I think it would be good if we could solicit them for some comments or something. But other than that, I agree with your request for that prior report. Thank you.
Representative Javner?
Thank you, Madam Chair. Yes, thank you for the ask of the report, definitely. I also am curious from the department's perspective, if the kinship program, I know that, okay, so AFFM is the provider of these kinship navigator services for us as of now. Is that not considered to be outside of the department? And also, if a kinship program were to operate outside of the department, really what would that look like if this is not already considered to be outside of the department? Thank you.
Anyone else? Seeing no further requests for additional information for the work session, I will close the public hearing on LD 699 and turn to our analyst, Erin Dooling, for additional work for us today to round out our afternoon.
If you have time and feel like it, we have 2 amendments we could review this afternoon.
I believe we have time.
Okay. Then I'm going to share my screen. Okay. Do you see a PDF document in front of you? Okay. So this is the amendment to LD 24. This was the bill presented, I think it was a department bill about changing some of the requirements around birth certificates. There weren't really any substantive changes to that bill that came out of committee as a unanimous committee amendment, but there are some technical changes. And so I just wanted to highlight those for you. The first one, the committee already discussed and talked about. That's in this on lines 11 and 12 here. This was the proposed amendment from the department that the committee specifically voted to adopt, which would just be to refer to the electronic registration system instead of the electronic birth registration system, because that system doesn't just cover birth certificates with the changes proposed in the bill. The subsequent changes are ones that arose in the course of my legal review. My legal reviewer, it's an internal review process we have, noted that in some sections of the bill, it referred to a biological parent, and in other sections of the bill, it referred to a genetic parent, and wondered what that distinction was. And so I worked with the judiciary analyst and the department, who confirmed that when the Maine Parentage Act was enacted several years ago, the intent was to update the language in the statutes to reflect the new terminology used in that, and to be consistent with the Maine Parentage Act, which would be genetic instead of biological. And so both that analyst and the department considered those technical changes, that there wouldn't be any substantive effect, but it would make the statutes consistent. And so you can see those changes throughout this amendment here. So at lines 13 and 14, then again at 19 and 20, and then periodically throughout.
Excuse me, Erin, the statute
Yes.
that you're referring to is the Maine Parentage?
The Maine Parentage Act was enacted a few years ago, right?
Okay.
But there were other sections of law that were intended to be updated as part of that. And these were some of the ones that was an oversight for not updating the language, is my understanding.
Thank you.
I know it's kind of hard for me to scroll and show you each individual area that's being changed. But in addition to the term genetic and biological, which you'll see throughout, we mentioned this when we did our how to read a bill presentation is that the revisor's office, if they're amending a section of statute, often takes the opportunity to make sure that it meets the current drafting standards. So in this subsection 4 here at the top of the page, the word he was used, and the statutes were directed to be updated to be gender neutral. And so the word he here has been changed to refer to the office that the person would hold, which is the office of the state registrar. Similarly, changing shalls to musts where appropriate, and this shall be would be are confidential. And so those are really considered technical changes to align the statute with current drafting standards. But I realize that's kind of a lot to throw at you because they weren't specifically discussed at the work session, but I'm happy to email this out to you all if you want a chance to review it before giving me the go ahead to ship it out the door, or I'll follow your lead, whatever you're comfortable with.
I actually would like a copy of this emailed to the committee, please.
No problem. So the next bill to review is LD 47, which is about the state's free health clinics. And this bill is in between processing. It's almost done, but you could see some of the markups that happen when we send the files back and forth with the revisor's office. The changes that you had adopted in this amendment are to
We're still
provide-
seeing LD 24 here.
Oh, no. Okay, hold on. Did that work now? I'm sorry about that.
It's working now.
Okay. You can see the PDF.
We can.
Okay. So in this one, you specifically directed that the funds be distributed to the health clinics through a grant process. And so you'll see that specific directive here, an unallocated law, directing the department to set the criteria and directing that as a condition of receiving the funds, the clinic provide information about how the funding would be used to the department, and then the department would be required in section 2 to report to this committee about how the funds were distributed through that process. The other change in order to effectuate the change to a grant process is to change the initiative language here on line 34. So instead of saying provides one-time funding, it clarifies for the fiscal folks that it's one-time grant funding. And I believe that you had already seen this is the same appropriation request that was requested in the bill. And all these other changes are editing, grammar type changes.
Thank you. Any questions from the committee? No?
So is that one ready to go out the door?
I think so. It looks like it meets the requests from the committee. So yes, I believe so. And
I
anyone?
will email both of them to the committee after.
Thank you.
And that's all I have.
Okay. Anything else? Nothing else from the committee today? Yes, Senator Moore.
Thank you, Madam Chair. I understand earlier today during our biennial budget workshop, I had to jump out to another call. I wanted to register my vote in support of that change to that line. So the answer would be yes.
Okay. Carrie?
Actually, well, I think I take the vote, but I had an appointment this morning, so I don't know which line. But I can check with Anna if that's not clear.
Thank you.
Okay.
And Senator Claxton.
If that's the vote that Senator Moore is referring to, that's in support of the 15 caseworkers being hired by the, that's the line I'd like to vote as in support of too.
Thank you. Seeing nothing else. Oh, yes, Representative Javner.
I apologize. I just want to clarify that that was actually a new initiative that was put into the budget that we had voted on. So there wasn't a line item yet for it. So.
Is this Representative Stover's amendment on ARPs?
It
No.
was the fiscal note that came from Luke this morning on the funding the 15 positions beginning October 1.
Okay, I got a text that Anna says she knows what you want, so I think we're sorry about that.
It was
No
that
problem.
additional quarter that we talked about yesterday.
Correct. Correct. Anything else? I would entertain a motion to adjourn.
So moved.
Second.
All in favor?